Good evening, ladies and gentlemen. Welcome to penultimate day, second last day of challenges in hematology. As we all know by now, this is a marathon web series truly of international order, which covers challenges in hematology and also has best of EHA 2022. Under the aegis of Mumbai Hematology Group, brainchild of our program director, Professor Dr. M.B. Agarwal, President Mumbai Hematology Group. We all know him very well, teachers of teachers, inspiration for all of us. No wonder that he has got the Inspiring Hematologist of the India Award. A warm welcome to all the three experts who are going to speak to us and also answer our Q&A sessions. The expert persons who are going to ask very interesting questions. Last but not the least, all the participating countries, almost 25 of them who are logging in since last 6 days. Thank you for your participation and a warm welcome to all of you. May I request Professor Dr. M.B. Agarwal, sir, to take it forward from here.
Good evening, friends, and thanks to Dr. Manoj for the kind introduction. Challenges in hematology, including the best of 27th Congress of EHA. Today is day 6. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS and managed by Perfect Square. I thank Dr. Manoj and his team from INTAS, Mr. Yash, Mr. Kalpesh, and the team, Perfect Square, Executive Committee of Mumbai Hematology Group, all our discussants who are themselves eminent hematologists or medical oncologists and pediatric oncologists, and you participants for sparing your Saturday evening, if you are from India, or morning or afternoon from the rest of the globe. Our website is very simple to remember, mhgindia.com. For all our academic activities, you can visit the website and keep yourself free for many of the activities which may be to your liking and to your interest. Our first guest speaker this evening is Dr. Kjeld Schmiegelow from Denmark. He's professor in pediatrics and pediatric oncology from the Department of Pediatrics and Adolescent Medicine, the Julian Mary Center at Rigshospitalet, Copenhagen University Hospital, Copenhagen, Denmark. And he's going to lecture today on toxicities in acute lymphoblastic leukemia due to host factors and can we prevent them. So, sir, go ahead.
Okay, I'll start sharing my screen. And these are just my disclosures. So the issue on toxicities has become more and more important in recent years, partly because our treatment has been diversified and in some cases becoming quite severe for subset of patients, but also because we have the opportunity today to do much deeper biomarker phenotyping and also mapping of the host genomics. So I will, over the next 45 minutes, walk you through a number of the toxicities that we see when we treat children, adolescents, and young adults with acute lymphoblastic leukemia, and how we should address them when we face them. Most of our treatment protocols have very clear guidelines on how to deal with the anti-leukemic therapy, but often there's little on how to deal with the toxicities. We have recently published a line of papers based on the Nordic-Baltic 2008 protocol, where we treated patients from 1 to 45 years of age. What you see here on the graph on the left is the risk group distribution. I won't go into the details of that distribution, but just emphasize that when you are just 1 to 4 years of age, the likelihood of being allocated to the lowest risk group is almost 60%, and the risk of being in need of a stem cell transplantation is less than 5%. In contrast, if you are above 25 years of age, almost 40% of the patient will receive very intensive block-based therapy, and half of those will also receive transplantation, whereas only 10 to 50% will be allocated to the lowest risk group. So even when we treat children, adolescents, and young adults across the spectrum on the same protocol, with the same diagnostic criteria, adults and adolescents will be exposed to much more intensive therapy, simply based on their risk factors. And I've highlighted 3 of those. It's partly due to them having a higher frequency of T-cell leukemia. They more frequently have MLL or KM2A rearrangements, and they have, not least for the bilineous leukemia, a higher end of induction minimal residual disease level. Due to this intensified therapy, the older patient will also face a higher risk of death in remission, but otherwise, except for the risk of relapses, they're very similar. For instance, in risk of induction deaths, CNS relapses, or risk of secondary cancer. But the risk of relapses is 17% in the adults compared to only 6% in the younger children. So one of the things we did in this protocol was that we across the board upfront defined 20 toxicities that we ask every clinician to register for each patient at 3 months interval prospectively. And our compliance rate to that registration was above 99%. And what you see is I've highlighted 4 toxicities where it's very clear that even in risk group adjusted odds ratio analysis, adolescents and young adults are very similar and clearly different from the younger children. So the risk of having hypersensitivity to asparaginase is lower in the older age groups, whereas the risk of pancreatitis, thrombosis, and osteonecrosis is higher in the older risk group. We won't have time to go through all these data in detail, but as you see on the left, where we put percentages of the toxicity across a number of publications that we have sent out, if you summarize these, it's very close to 50% of all our patients that will have 1 or more of these toxicities. So how can we avoid them? And you can say basically there are 2 approaches. One approach is, of course, finding a way to provide primary intervention, that is giving some kind of prophylaxis before the toxicity occurs. It can be antibiotics to avoid infections, it can be pre-medication for hypersensitivity reactions. It can be low molecular weight heparin and other strategies, and I'll come back to a few of those. The other issue, which is at least as important, if not more important, is what do you do when these toxicities occur? And most of us, and even patients and parents, fear them so much that there's a trend that treatment is truncated when a guilty drug is encountered. If we look at the toxicities that quite frequently lead to truncation of asparaginase therapy, and I highlight asparaginase because it has become really an essential drug to ensure cure, hypersensitive pancreatitis, thrombosis, and hyperlipidemia is quite common. But we also see hepatotoxicity, which is low in the young patients, in the non-obese children, but as you get older and fatter, the risk clearly increases. Also encephalopathy with hyperammonemia. We recently published a paper in European Journal of Cancer demonstrating that whether you give asparaginase intramuscularly or intravenously, this may differ on the convenience for the patient, but it doesn't change the risk of hypersensitivity reactions. but also a number of papers from the Nordic group have demonstrated that when you are obese, is a clear risk factor, both for toxicity, for risk of truncation, and for the risk of relapse. If we look at the adult patients only, a number of papers have come out that emphasizes that for asparaginase, but one of the most common toxicities is hepatotoxicity, which is really a clinical burden for many of our hematology colleagues. But also CNS toxicity can be quite cumbersome for the adult patients. Presenting themselves as fatigue or clear encephalopathy, and much of that will be associated with hyperammonemia. Here you see how these toxicities in the liver is associated with BMI. And for all of those, as you get bigger, the risk of transaminitis and even hyperbilirubinemia clearly goes up with the higher BMI, being close to or even above 50% for the most obese patients. Adults have tried to avoid this either by postponing asparaginase introduction until after the myelosuppressive phase, that is at the end of the first 1 month induction therapy. And there's some data that indicate that L-carnitine may ameliorate the therapy. At least some preclinical models demonstrate that, but it's only now that it gets tested in a clinical trial. This is from the paper we published in Blood last year, where we looked at why do patients have truncation of asparaginase therapy. As you see on the first highlighted line, the vast proportion of patients that have truncation, in fact, more than 50% of all truncation, is due to clinical hypersensitivity. And then down the list, you have pancreatitis, thrombosis, hyperlipidemia, liver toxicity, and various other features. If you look at the second last line, asparaginase inactivation, in practice, not only do patients that have clinical hypersensitivity in more than 90% have loss of asparaginase activity, in this case, 139 out of 157 patients. But in addition, approximately 5% will have silent inactivation. This means that they can seemingly tolerate the drug, but it has no effect, only cost. This is why we recommend to do therapeutic drug monitoring. Does it matter? Well, if you truncate therapy because one or other toxicity, all studies that have been published so far demonstrate a trend or clearly significant difference in outcome with a higher risk of relapses or lower event-free survival in those patients that have the truncated therapy. On the bottom, I have the recent Nordic study, and that study we went a bit further than the conventional registration in that we also added measurements of activity. So these are the survival curves. On the top red curve, you have patients that we say have low intensity therapy because they either have truncated their therapy receiving less than 10 weeks, or they have no measurable asparaginase enzyme activity. So they were not exposed. On the black lines at the bottom, you have those that have high intensity, meaning that they received all their asparaginase doses. And when we measured their blood concentration, it was measurable above the standard level of 100 international units. For those that had the lower treatment intensity, the hazard ratio is increased by 70% compared to those that had the full therapy. So when you look at patients that seemingly have some kind of hypersensitivity, there's basically three groups. There's those that have clinical hypersensitivity that can go from very mild rashes and discomfort to clear life-threatening anaphylaxis. The important thing is that this clinical hypersensitivity, even if the reaction is mild, it is very closely associated with asparaginase inactivation. And even though you can, for these patients, subsequently give them antihistamines and steroids, this will not mitigate the inactivation. You need to switch to an alternative asparaginase formulation. For those that do shift, also 10% of those will subsequently react to Avinia. And then, as I said before, you have in the order of 5 to 10% of patients that have very rapid elimination of asparaginase due to antibodies. These are the international definition of silent inactivation. Either you already, when you receive PEG, have an activity of less than 100 on day 7, or it's below the lower level of quantification at day 14. And then you have patients that have intolerance. It may be 1 to 5%. So they seem to react, vomiting, stomachache, rashes. Very often it's not antibody mediated and it doesn't inactivate the drug. But very often these patients have high levels of ammonia and that can explain their symptoms. These intolerance reactions tend to come later than when you have asparaginase infusion that often occurs already at the first drops. The only way you really can distinguish between this intolerance and the clinical hypersensitivity is by doing therapeutic drug monitoring. Another important paper was a study that came out from COG a couple of years ago, where they looked at patients that had all their PEG asparaginase doses replaced by Avinia in case of hypersensitivity. They compared such patients with those that didn't have any responses, so they received all their doses, and then a group of patients that missed their asparaginase doses. And for those where you stopped asparaginase therapy so they didn't have Avinia replacement, the risk of relapse went up by 50%, and that was both the case in the high-risk group and also in the standard risk group, at least for those that had a slow early response. Pat Brown's group in the US have tested where you can pre-medicate yourself out of these problems, and many have taken that on subsequently. So 20 to 30 minutes prior to asparaginase administration, you give your patient antihistamines, you can give them an H2 receptor antagonist to avoid the gastrointestinal symptoms, or even steroids, and that will reduce the hypersensitivity reactions. But of course, if you do this pre-medication, you must monitor the asparaginase activity in the blood. So we regard now therapeutic drug monitoring as mandatory, and recent papers have also demonstrated that it's highly cost-effective. It's effective in the way that if patients don't have any measurable activity, and if you don't have the option to shift to Avinia, well, you can just stop the treatment and then save at least your PEG asparaginase cost because it doesn't work anyway. But also, if you want to shift, you can shift only for those patients that really needs it. And then let's move on to another thrombosis. This is from a very large Nordic cohort of almost 2,000 patients from the age group 1 to 45 years of age, where in total, almost 8% of all patients at some time during the therapy developed a thrombosis. As you see from the Kaplan-Meier curves, the risk of thrombosis was quite low in that setting on the Nordic Baltic protocol because we didn't use PEG asparaginase during the induction therapy. Overall, the risk of thrombosis is less than 5% for patients less than 10 years of age, but goes up to 15 to 20% for the adolescents and young adults, being very similar between these two groups. We know some of the mechanisms, both we know genetic mechanisms, and we know that asparaginase can deplete and steroids increase a number of the thrombotic factor in our bloodstream that plays a role by being prothrombotic or antithrombotic. The question is then, of course, what should you do when you have these patients? we recommended over these years that you should re-expose your patients once you have started low molecular weight heparin therapy. And I think that's a strategy across most of the world. However, there's a subset of patients where pediatric oncologists and adult hematologists really worry, and that's patients that have cerebral sinus venosus thrombosis. So we recently looked on that subset specifically. So what you see here is a table of 46 patients that have cerebral sinus venous thromboembolism in our protocol. They're distributed across the 3 age groups. 20 were less than 10, 15 was 10 to 17, 11 were adults. And across the board, approximately 3 out of 4 patients were re-exposed. And of course, those that were re-exposed had a tendency to be those that had their therapy otherwise being truncated very early on during their therapy. But note that adults and pediatric hematologists were equally prone to re-expose their patients. Among those 31 patients that were re-exposed, only 2 patients developed a second thromboembolism. One of those was a similar episode in the central nervous system. However, when that patient was followed up, there was complete normalization, both of the clinical symptoms and on the imaging. And on follow-up, with a median time of follow-up of 4.5 years, the risk of neurological sequelae, the likelihood of recanalization of the venous, and imaging did not differ between the re-exposed and non-re-exposed patients. So based on these data that have been published in British Journal of Hematology, we recommend re-exposure for these patients once you start low molecular weight heparin. So that doesn't really differ between whether it's a CNS thrombosis or a more systemic thrombosis. So far, there's only one published study that randomized patients to receive or not to receive thromboprophylaxis. This is a study from Germany and Switzerland, run in the early zeros, including both children and adolescents. And patients were randomized to 3 kinds of thromboprophylaxis within the first 33 days of therapy, and then observation until the end of consolidation. One arm received crude heparin infusion. One arm received low molecular weight heparin provided subcutaneously, and one arm received antithrombin substitutions routinely. And what that study showed was that there was a clear effect in the reduction of risk of thrombosis, both in the low molecular weight heparin and in the antithrombin substitution arm, compared with those that received low dose unfractionated heparin. That effect was strongest in the older patients above 6 years of age. But please note that 33% of all children or parents refused the subcutaneous administration because of the discomfort. And that, of course, makes the data less easily to interpret. And also that those that received antithrombin had an increased risk of relapse, so they had a lower event-free survival, even though it's uncertain whether this is a random finding. It didn't reach statistical significance. We recently published a Cochrane review where we looked at all randomized adult studies. In total, there was 3 non-randomized studies and no randomized studies. So that's really a need. And we couldn't demonstrate any benefit of giving prophylaxis of any kind to the older patients, including young adults. A critical question is whether you should, when you give low molecular weight heparin, also provide antithrombin, because heparin works through antithrombin. So many centers, including ours, always substitute these patients when the antithrombin goes below 0.5. What about the more modern oral anti-thrombin drugs, and we are still awaiting result of randomized trials, but they are beginning to be, they are running, and we anticipate to get the first results of these in a few years. What about pancreatitis? Also another feared toxicity. And what you see here in this Kaplan-Meier plot of almost 2,500 patients covering the age of 1 to 45 years of age, that as you get older, the risk increases, but it really already increases from the age of 6 years. So whether you are 5 to 8, 9 to 16, 17 to 45, the risk is the same. And it's only when you have the very young children below 5 years of age that you have a risk that is half of that. Of note, many of the adolescents and young adults will have quite severe complications associated with the pancreatitis. It's the need of mechanical ventilation, it's development of psoriasis, it's recurrent pain reflecting chronic pancreatitis. But also the risk of getting permanent insulin-dependent diabetes doubles once you go beyond the age of 10 years. So should you re-expose your patient after pancreatitis? Well, we generally recommend re-exposure, and we do that because truncation of therapy is clearly associated with a high risk of relapse. And it's much, much more likely that any of your patients will die from leukemic relapse than from pancreatitis. So here I have the data from 2 studies. The Ponte de Linho study is an international study where we collected data on 465 asparagine-associated pancreatitis cases, and subsequently the Nordic study I just showed you. The data is very similar. Almost 50% of the patients that you re-expose will get a second episode of pancreatitis. But very importantly, if you look at the bottom line, the median number of doses that patients can receive before they have the second episode is 3.5 for the children. And if you look at the adult cases, there is a trend that they have a high risk of pancreatitis already at the first dose, but it's still only 1/3. So when you have a patient with pancreatitis and you're considering whether you should re-expose, there's 2 questions you should ask yourself. The first question is, what do I think is most likely to kill this patient? Pancreatitis or relapse? And then that leads to the second question. What do you anticipate the relapse risk is really for that patient? So if we had a low risk, standard risk patients that had no CNS involvement at diagnosis and have received most of his doses, we would probably stop asparaginase therapy. But if we had adolescents or young adults that have several risk factors, we'll be very prone to re-expose this patient to asparaginase. Overall, on first-line therapy, approximately the risk of pancreatitis is 1% per dose, and it increases massively, but it's still only around 10% per dose at re-exposure. Then let's move on to osteonecrosis, another very feared toxicity. The frequency varies depending on how focused you are on this toxicity and which means you use to detect it. Most are subclinical and only detected by MRI. But if it is symptomatic, the grading is relatively high. And for those who develop severe osteonecrosis grade 4, more than 90% will have persistent pain, either always, that is every day, or quite frequently. We know a number of clinical risk factors like older age, female gender, where you use the more intensive steroids, dexamethasone. There are some host genome variants, although they are not the same across the various studies. And then, of course, hyperlipidemia. If we look at when these osteonecrosis cases occur, many of you have experienced that it's not when you give the steroids, most of the cases occurred during maintenance therapy or after maintenance therapy had been truncated. So we recently did a very large study of 1,200 patients in the Nordic setting, where we collected 17,000 blood samples that we measured for the various maintenance therapy metabolites, red blood cell levels of methoxate polyglutamate, thioguanine nucleotides, methylate mercaptopurine, and DNA thioguanine. And none of those were associated with the risk of osteonecrosis. Or therapy, where you may link it to something else or classify it as something else rather than the previous anti-leukemic therapy. Across the board, females seem to have a higher risk than males, although that may not be the case for the adults. One of the few risk factors that people consistently associate with the risk of osteonecrosis, and this is from one of our studies some years back, is hyperlipidemia. It's both decreased lipoprotein lipase that can be associated with asparaginase, but also it's increased levels of very low density lipoproteins. Here you see just the peak triglycerides. If they're above or below 18 as a peak value during delayed intensification, the risk of osteonecrosis is clearly very, very different. So there's a need to focus on hyperglyceridemia more intensively. We know it's common, and we more or less understand the biochemical mechanism that makes asparaginase and steroids cause hyperlipidemia. Mostly it's without any symptoms, but it may compromise the routine lab work, and sometimes we don't recognize this toxicity until the lab calls us and say, now we once more have ruined their machines. And more importantly, it's manageable. You never should change patients' diets. It doesn't help at all. But you may be able, by various drugs, fibrates, or insulin, or even plasmapheresis in emergency situation, to reduce the levels. Omega-3 have been shown to be very effective, and we are now running a randomized trial to test whether giving fish oil that is long-chain omega-3 can reduce the lipid levels, and also whether it can reduce the toxicities associated with hyperlipidemia. We know osteonecrosis clearly is associated. It's much more questionable whether thrombosis or pancreatitis is associated with hyperlipidemia in leukemia patients. We know in non-leukemia patients, it clearly is associated, but these very short exposure of high levels is probably not really a risk factor for the other toxicities in children with leukemia. So that's the main lessons for this issue. Very few genetic variants have been associated with toxicities. We've done a few studies on thrombosis, and I may have time to come back to that. Here's one of the genes that's been quite extensively studied. It started off in St. Jude, where they across several protocols could demonstrate that children, patients, and also cell lines and animal models, if they had the microtubule centrosomal protein variant, so it's a promoter, the CEP72, the TT variant, the risk of neuropathy went up very strongly. And as important, the cells, the leukemic cells, also increased their sensitivity to the drug. So the fact that you have more toxicity, but also better efficacy, did indicate that you may be able to reduce the dosage for these patients and see where that works out. And currently, the St. Jude Hospital is running a randomized trial where they try to either lower the dose or shorten the exposure. A number of studies, also in adolescents and adults, have confirmed these findings, but not all. So please note that in the first St. Jude protocols, the number of doses were 36 to 39 increasing doses, and many of the protocols that we use currently expose the patients far less intensively. So if you read the papers and find them discrepant, it may simply be a reflection of the dose intensity. And then something that's quite close to my heart. In my institution, our cure rate for children, that is survival rate for children with acute lymphoblastic leukemia above 1 year of age, is now 94%. So we seem to be able to cure most of our patients in first line or second line or third line therapy with the normal immunotherapies, inotuzumab, blinatumomab, of course, CAR T-cell therapy, relapses, and other drugs that's effective for T-cells like venetoclax or bortezomib or nelarabine. So more and more patients get cured, but they get cured to, in some cases, a really burdensome life. So we recently published a paper where we had a new measure for outcome, which we call severe toxicity-free survival. So what you see on this plot is the classical outcome measures, overall survival, where you die from the treatment or die from leukemia. And of course, event-free survival that also includes resistant disease, relapses, and secondary cancer. And these are at a decent level currently across most of the patients that are treated with contemporary protocols. However, we should take into account with these high cure rate, what is the risk of unacceptable severe long-term toxicities like severe no cognitive impairment or the need for organ transplantation. So we went through 855 toxicities that are listed in the CTE AE criteria. And in an international setting across multiple working groups, we boiled it down to 21 prioritized severe toxicities. And I won't have time to go through all of these, but you can probably recognize that if patients have liver failure and need transplantation, if patients become blind or have hearing loss or need a replacement of their hip or have very severe cognitive dysfunction, there's a number of these toxicities that most of us will agree is really unacceptable. And we need to understand how frequently do our patients encounter at least one of these. So we've started a study now across 5 leukemia cohorts, the Nordic cohort, where it's the same protocol across 7 countries. The St. Jude cohort, which is a very research-intensive institution where all patients are seen. The Dutch group is a large national cohort, and Poland and Australia that have several cohorts with various distinct protocols. And we want to see whether we can use what we find here to have a better strategy, not just for global implementation, but also on how we should report our outcomes in the future. This will make us understand what is the true incidence of these unacceptable toxicities across various treatment settings, across various protocols and strategies. So although we may reach very similar outcomes, the use of steroids, the use of central nervous system irradiation, the use of transplantation or immunotherapy, the use of asparaginase, all these different settings in the leukemia therapy plays a role for the profile of toxicity. The second goal is, how does these objective toxicities defined by physicians associate with patients' own subjective measure of the burden of life? And lastly, how does the culture, the country you live in, influence the perceived burden? Do you have full health coverage? Are schooling provided? Can you manage a protected job and so forth? So once we have analyzed this across the 5 cohort, we'll go more global and identify patients across the globe, including in India would be great, to see how does the culture influence how patients perceive their burden of toxicities. In addition, we now created what we call the Elegance Study, which is a collaboration between 33 countries, most of the European countries, Australia, and 3 countries in South America, Argentina, Uruguay, and Chile. And we are now starting collecting blood samples early on during therapy on up to 20,000 cases. And then we want to link phenotypes to these genotype profiling to have a deep understanding on how the host genome variants influence the outcome of our patients. So the platform will address not just exploring leukemia, but also provide education and a novel strategy for mapping the genetics and doing artificial intelligence analysis. So the challenges that we face, how should we deal with those? So in summary, you need to do deep phenotyping, and we have been moderately sloppy at that. When I report thrombosis, or when you report thrombosis in Asia or in Africa or in South America, we may identify our patients and classify our patient differently. We need to have clinically relevant odds ratio. Multiple papers are published that provide very nice odds ratios. They may even end up in Nature, but it needs to be clinically relevant. That means it needs to explain the toxicity for the majority of our patients. We need to register the exposome. Age and of course pubertal stage plays a role, but other exposures like chemotherapy, inflammation, endothelial dysfunction, the microbiome and so forth plays a role as well. And then we need to map our omics in various ways. We need to address very complex bioinformatics strategies, including machine learning. And we need to show that our finding can be reproduced across cohorts. It would be nice, although it's not always easy, to do biological validation. And then we need to have intervention that are clinically applicable and acceptable both for physicians and patients. So the reason why the genomics are not integrated in our care today is because it's a long road for each SNP or gene that we find to be associated. This was my last slide. I have a few minutes left before we go to the question. I just want to demonstrate one example to you, which may be beneficial if we want to move a bit further. So if we look at a candidate gene exposure, and that's something we can do in relatively limited cohorts. So you can do it in India, we can do it in larger Asian settings or African settings or South America. There's of course a lot of things that we know about the human biology. And if we take thromboembolism as an example, multiple studies have been published on thrombosis in adult patients. And a meta-analysis of 7,500 thrombosis cases and 53,000 controls identified across the board a number of genomic variants. What we then did use the candidate gene approach and said, does these variants also predict thrombosis in our leukemia patients? And fibrinogen variants and factor 11 variants were also associated with the risk of thrombosis in our patients. And then we then added the known risk factor, that is age. What we found is that for the young patients, the risk of thrombosis remains very low, whether or not you have these variants. And we made a cutoff. Did you have less than 3 of the variants, or do you have more than 3 of the variants? For the adult patients on the right, the risk of thrombosis is around 20%, irrespective of your genomic profile. But for the adolescents, those that had 3 or 4 alleles, they had 3 times as high risk for developing thrombosis compared to those that had only 1 or 2 or no of these risk alleles. So when you want to consider thromboprophylaxis, this is one way to identify the subpopulations that can be benefited from such an approach. So you could say many of the interventions that we provide to our patients, we can use candidate gene approach and even GWAS analysis. And even though you may be in doubt whether these genomic findings associated with phenotypes are really highly significant, at least they can be used as a guidance to provide power to your study. So I'll stop here with this last slide, and then be happy to take questions. Thanks a lot for your attention.
Thank you, Dr. Kjeld Schmiegelow. That was wonderful. You updated us with various novel aspects of these toxicities, their mechanisms, and the underlying genetic factors. So we have got some of the Indian colleagues who would like to interact with you, starting with Dr. Roshni.
talk. I wanted to know your experience in re-challenging with intrathecal methotrexate or systemic IV methotrexate after the patient develops a stroke-like syndrome.
Excellent question. I apologize, I didn't address it in my talk. So as part of an international group I'm sharing, the Ponderlinear Toxicity Working Group, we have together with Chris Halsey in Glasgow collected 1,500 patients with no toxicities during therapy. And several hundreds of these have stroke-like syndrome. When you re-expose patients after stroke-like syndrome, and for those who don't know it very well, stroke-like syndrome is a toxicity that is induced by metabolites of methotrexate blocking the NMDA receptor. So patients behave as if they have stroke. So they may have paresis, loss of consciousness, speaking problems. It starts very often like 1 week to 10 days after the exposure, and then it can last fluctuating, waxing and waning for approximately up to 3 weeks later. When you re-expose the patient, the risk of a second episode is in the order of 10%. So it's not zero, but it's quite low. And because we know the mechanism that is the blockage of the NMDA receptor, you can target that receptor by giving them theophylline, the asthma drug, or you can give them dextromethorphan, which is what we use routinely. Dextromethorphan is a coughing drug. You can buy it off the counter in many countries in the world, and it's quite effective. So we start giving that a few hours before we give the methotrexate, and then we continue until a few days after the therapy has been stopped. And our experience is that not always, but in most cases, it works quite effectively. And sometimes when you have a patient with stroke-like syndrome, the patient is completely confused, unable to speak. The patient may have hemiparesis, and then you give them dextromethorphan, and sometimes even within half an hour, they suddenly sit up and are completely normal. So it's like a medical miracle when you do it. So it's worth testing, and it's really atoxic. So another toxicity that can be quite similar is that you accumulate purine nucleosides, including adenosine, that tends to become early on. There, theophylline is effective, and it sometimes can be difficult to distinguish between those two. And then lastly, approximately 10% of our patients will have seizures, and it can be caused by, of course, PRES, as you know. It can be caused by vascular problems. It can be caused by stroke-like syndrome, and it can be quite hard to know what is what. We recently published a paper, I think within the last few weeks or months, where we demonstrated that patients that had even very low level leukemic cells in the spinal fluid, not detectable by normal cytospin, they have an increased risk of neurotoxicity. So we're beginning to understand why these toxicities develop. But for your specific question, stroke-like syndrome, yes, you can re-expose these patients. 90% will tolerate the drug again.
And is there any way to prevent or identify PRES early? Because it's quite debilitating if you identify it late.
Yes. So we don't know how to prevent it. And I don't know of any preventive randomized studies. It's certainly doable. If you feel that you have a population where these risks are higher for some genetic reasons, a randomized study will be extremely welcome. The risk of stroke-like syndrome, which is sometimes missed because clinicians don't recognize it, is probably in the order of, let's say, like 5 to 10%. And that's the same for PRES. PRES is coming often during induction therapy, clearly associated with low-level leukemic infiltration, but there's currently no study that have been using preemptive therapy. Once you recognize it, at least one thing you should do is lower the blood pressure. And some of these patients will have blood pressure that seems normal, but it's in the upper range. And you don't know what was that patient's prior to leukemia. So we even lower the blood pressure for these patients.
Thank you so much, sir.
Thank you. Dr. Chandra?
Thank you very much, sir. Very, very excellent talk. I have 3 questions. First one is, what I understand is you have been talking about all factors related to PEG asparaginase. Do all those things apply to conventional asparaginase? That's first question. Second thing is, what exactly...
Dr. Chandra, one by one. Yeah.
Okay, so yeah.
So you can answer the first question.
So the first question is there difference between the different asparaginase formulations? So if we take hypersensitivity, that is allergic reaction, it's clearly higher in the native E. coli asparaginase, so that's lower with the PEG formulation. When we talk about the allergy-like reactions, that is the intolerance, but you don't inactivate the drug, that is more common with Avinia asparaginase. And one of the reasons why Avinia asparaginase provides a higher risk is that it also have a high glutaminase activity. So when you give asparaginase, it's not just asparaginase, it's also glutaminase. And Avinia asparaginase have a higher glutaminase activity, so you provide more ammonia. There you can, if you have that experience, you can lower the dose or you can prolong the infusion time. When we talk about the other toxicities, that is the risk of hyperlipidemia, the risk of pancreatitis, the risk of thrombosis, this is clearly associated with the asparagine depletion, and there the risk is the same. If you deplete the drug, then you have deplete the amino acid, then you have the risk. So no difference between the drugs and these toxicities.
Thank you. The second question is, if somebody develops a CNS bleed, which is not related to the low platelet count, what is your recommendation in re-exposure?
So you have multiple coagulation disturbances. Bleeding is relatively rare, but of course that is seen as well. Our general consideration is, as I said before, what is the major threat to the patient? And since we have a relapse rate, even in our setting around 10%, and in many places around the world, depending on the protocol, it may even be twice as high. This is what kills most of our patients. So if the patient have normalized the neurology, not so much the imaging, that can take time, but if the patient have normalized the neurology, and most of our young children, both with bleeding and with thrombosis, tend to normalize relatively rapidly, we always re-expose these patients. It takes time to convince the parents and the patients. So we always try to prepare well. Sometimes we give literature to the parents, but they really need to understand that what we decide is not based on a gut feeling, but that is based on scientific data.
Thank you. And the third question, if time permits, what exactly you mean by truncation?
Truncation is just you stop the therapy. So very frequently we see, for instance, if you have a patient with pancreatitis, and I mean, most of these patients have severe episodes that go into intensive care, sometimes mechanical ventilation. It's very stressful for the nurses, for the physicians, of course, for the patients and parents. And if you come back and say, oh, now we want to re-expose, many will refrain from that. So that's what I call truncation. And it's whether you truncate because of thrombosis, because of pancreatitis, or because of hypersensitivity, you increase the risk of relapse. So consider what is the risk of relapse and try to give the therapy that the patient were expected to get anyway, and then see whether some measures you can give. Most of our patients still will tolerate a re-exposure, including in case of pancreatitis, at least a certain number of doses, and that will reduce the risk of relapse ultimately.
Thank you very much.
Thank you, Chandra. Dr. Akanksha.
Sir, good evening, sir. Thank you for the very elegant and comprehensive talk. Sir, I'd like to ask regarding the mutation enzyme activities of TPMD and NUDT15. Should it be routinely done in patients before starting them on 6-mercaptopurine? And second is that are you doing DNA thioguanine levels in measuring the treatment intensity in the patient?
Okay, so two different questions. And I can say for those of you who are interested in maintenance therapy, we just published a very large review in leukemia. It's available online for free, which we published together with the people at St. Jude. So we know that in Europeans, TPMT, heterozygosity, and even deficiency is relatively common, whereas in Asia, including India, the NOT-15 is far more common. We do genotyping on these parameters for all our patients. routinely now. And in addition, I'm running a very large European study where we will be collecting maintenance therapy samples for 7,000 patients and doing, 50,000 metabolite measurements. We measure DNA-TG routinely. We have previously, both in our Lancet paper, but also later on in a leukemia meta-analysis, demonstrated that it's clearly associated with the risk of relapse. And we also recently published a strategy on how you can increase the DNA-TG. The problem is that in addition to these two variants that you mentioned, TPMT and not T15, when we look at individuals with Asian ethnicity, there's still a trend to tolerate lower doses, even when you adjust for not T15 and TPMT. So there's a lot of things to learn in addition to these two variants. So we don't know everything about the story. The question is, when you measure the metabolites, whether they add anything. So for the deficient patient, they clearly do. And if you don't do the measurements, you will have encountered these patients very rapidly on during your consolidation or the late intensification on the maintenance therapy. So I think clinicians in most places will recognize this. And just by knowing that they're there, you may accept to give a lower dose. But you need to do the monitoring. These patients will never tolerate the full dose. And there's a number of examples where clinicians try to consistently increase to reach the target dose, and patients have multiple treatment interruptions, and eventually they will relapse. There's a surrogate marker that we recommend for TPMT, because if you have wild-type TPMT, you will have very high methylated metabolites and aminotransferases. So you can use, you could say, aminotransferases as a surrogate marker for TPMT wild-type, but we don't have biomarkers for not T15. Did I respond to your question?
Yes.
Okay.
Thank you so much.
I get a simple question and I have a very long answer.
No, sir, perfect. We are enjoying it. We have a couple of minutes left, so we'll have two last questions, one from Chirag and one from Dr. Manas.
And then there's one question on the chat as well.
Okay. So
yes. So, quickly, when there is a delayed treatment due to cytopenia or myopathy or fatigue, should we complete that like as late treatment, so the total treatment goes from 6 months to say 7-8 months, or at some point we should kind of just omit and go to the next level?
Yes,
say block of era C.
Yes, and I can only say what my personal attitude is, because we don't have any studies demonstrating that. We have previously analyzed whether it was beneficial to give a year and a half or 2 years or 3 years of therapy. And we review all that in our leukemia paper on maintenance therapy. And that doesn't seem today to be a need to go beyond the 2 years of therapy. Now, some patients have a lot of toxicity, so they have long treatment interruptions. And when I analyze in the Nordic setting from our registry, when I analyze whether patients who have a lot of toxicities and thus treatment interruptions do worse than other patients, that is not the case. So you could say that they probably have these toxicities because the pharmacology had provided them with a more intense therapy. So that's one argument I use to parents and say, okay, you're right, we truncated some of the therapy, but it's probably a reflection that your patient are more sensitive to the drugs. Once you start prolonging the therapy, these attempts are never randomized. So there's no studies. We have analyzed in the Nordic setting where we had the exact date where patients stopped. There was no indication that those that continued because they had these interruptions did better or worse. So currently we say you stop after 2 years and 1 month, irrespective of what happened prior to that.
Even in the intense phase, the 6 months initial, we should apply the kind of same policy that if possible you complete but not push too long. And
yeah, so when it comes to the intensive phase, so on protocol it may last 6 months, and some patients then it lasts 7 months or 8 months. The intensive therapy is just eating the duration of maintenance therapy. So say you stop it at the same time, but you don't have the same duration of maintenance therapy added. I'm not convinced that that is the right way to move forward, but we need additional data. So one of the problems we had previously is we don't really understand how maintenance therapy works. And it's not, I mean, it's a different killing mechanism compared to our intensive therapy. We are currently trying to explore that in mouse, I don't know, in animal models. But at least for your question, no, we won't extend the therapy. The problem is when you have a specific treatment phase, like you say, consolidation therapy, it needs to last, let's say, 60 days. If patients have interruption, should you then prolong? And the main reason why you have this delayed in that phase is because of differences in tolerance to 6-mercaptopurine. And those that have the toxicity very often have a more, you could say, beneficial metabolism because they have some reason for accumulating very high levels of metabolites, or they have some genetic defect, so they are more intensively treated. So I normally say to my parents that, on my patients, that he's well exposed, but I don't add extra delays or extra days of 6-mercaptopurine. Once they've had the last ROC dose, then we stop.
Thank you. One last question, Dr. Manas.
Very quickly, do you think there is a role of bisphosphonates in the prevention or treatment of avascular necrosis associated with ALL therapy? That is my first question. And the second question is regarding thrombosis. So if a person develops thrombosis and you are doing a low molecular weight heparin to prevent the next thrombosis with asparaginase, do you give them a single dose of low molecular weight heparin, or you maintain them with twice a day low molecular weight heparin as a prevention therapy for your patients?
Okay, so I'll take the last one first. We give it once a day. Okay, so for the first question, it's a bit more tricky. So it's used for selected patients, and there are papers coming out that, you know, they're not randomized, but in retrospect, it seems to be beneficial. My proposal would be, and you have, I mean, at least in India, you have huge patient cohorts. I would recommend that you do your analysis on the lipids. If you confirm what we've demonstrated, the association between lipids and osteoporosis, then you would know already during the delayed intensification which patients are at risk because they have the high lipid levels. And then for these patients, you could select to randomize to receive or not to receive biphosphonate as a prophylactic measure. The question is, however, whether osteonecrosis is a bone disease or a vascular disease. And personally, I believe it's a vascular disease. But there's a healing process as well. So we are currently studying endothelial markers. We had a paper last year where we looked at endothelial biomarkers for thrombosis, very strongly associated with thrombomodulin. So many of the endothelial biomarkers are massively increased during therapy of leukemia. So the vasculature doesn't function well, and the combination of perhaps a vulnerable bone structure, endothelial damage, and then hyperlipidemia may be the combination that does the trick. And it could be that you identify your risk patient by the lipids, and then you randomize to receive or not to receive biphosphonate as a measure. That would be a great study to do.
So do you give biphosphonates for
we don't do it only if we have patients with very severe osteoporosis who are in pain.
Who are in pain. Okay.
Yes.
But
that is anecdotal. That is anecdotal. That is based on other types of patients where it's been beneficial.
Thank you, Dr. Schmiegelow. That was wonderful. You gave us a beautiful talk, and we had a wonderful question and answer session. Thank you for accepting our invitation, being with us, and enriching us with all your experience. Thank you.
I'm looking forward to come back face to face.
Mumbai.
I will.
Right, sir.
Okay.
Bye-bye.
Have a nice weekend.
Thank you. It's my pleasure to introduce our second speaker of the day, Dr. Eunice Wang. She has been our speaker in past as well. Briefly, she is Chief Leukemia Service, Professor of Oncology, Department of Medicine at Roswell Park Comprehensive Cancer Center, Buffalo, New York. And she is going to speak to us on case-based discussion on acute myeloblastic leukemia in 2022. So Over to Dr. Wang. You are muted, Dr. Wang.
Thank you very much. I'm delighted to have the opportunity to speak once again to your group. I'm just going to try to show my slides. Hold on one second. Can you see them now?
Yes, perfect.
Great. So I was asked today, and feel free, because I know we've met before and spoken before, to ask any questions that come up during the presentation. I was asked to provide an update on new developments in AML therapy and to present it in the format of some case presentations on how they might be relevant to your current and future patient population. So I think I have about an hour. I'm going to speak for about 45 minutes and give another 15 minutes for any questions. Can everyone can hear me okay? Okay, great.
Yes.
So acute myeloid leukemia, as we know, is an aggressive hematologic malignancy affecting largely older adults. We have known through decades of genetic and flow cytometric analysis that this is a very complex biological disease. And we now know through the last decade of next generation sequencing and whole genome technologies that AML is actually many different molecular subtypes. You can see here a graphic showing the most common mutations found in acute myeloid leukemia. And again, I'd like to highlight that when you look at this list, that no one mutation is found in more than a third of patients. So about a third of patients are going to have mutations in the FLT3 gene, but even among this gene category, there's not consistency. 2/3 of these would have ITD mutations. Some will have TKD mutations. NMP1 is found in about 29%, DMNT3 in 20%, and all other mutations found and identified in acute myeloid leukemia occur in less than 10% of patients. You can see here, there also is significant complexity in that many of these genes are co-mutated. So the ribbon graph on the left side shows the width of that ribbon graph shows the percentage of cases of that particular mutation that occur in conjunction with another mutation. You can see, for example, about half of patients that have NMP1 mutations are going to have concurrent mutations in FLT3. NMP1 mutation is also commonly co-mutated with IDH1 and DMNT3A. So this complexity and heterogeneity increases the difficulty in potentially selecting the best therapy, because in conjunction with these biological changes, we have heterogeneity in clinical responses in our patients. Recently, we've been trying to exploit these the underlying biology of AML by developing many what we call mutation-driven approaches to treat patients with this disease. And many of the new developments over the last 6 to 12 months are focusing on further developing and expanding mutation-driven AML therapy to increase its efficacy and make it more applicable and of longer duration for our patients with AML. So today I'm really going to highlight some cases of some different mutational subsets and what the most recent data is and how we are treating these patients moving forward. So here I've highlighted some of the most common, what we call actionable mutations in AML, i.e. mutations that we use not only for prognostication, but also for therapeutic targeting. And these are some of the regimens and newer developments in each of these subtypes that I'll be going through today. So in keeping with the desire to keep this patient focused, I've presented throughout my talk numerous case presentations of my patients, which may be eligible or were treated with these newer regimens. So the first case is this gentleman, a 60-year-old Jamaican man who had actually no significant prior medical history, who presented to an outside emergency room a couple years ago with several days of fevers, lower abdominal pain, and he actually reported incidentally that he had some loss in vision in his left eye for some time. He was noted to be febrile, and they did an infectious workup that suggested he might have a kidney infection. So he was started on some empiric antibiotics. On exam, he actually looked really good despite his symptoms, and really unremarkable exam. However, his laboratories demonstrated significant abnormalities. His white count was elevated at 51,000 with 44% blasts. His hemoglobin was low, his platelets were low, and he had a degree of renal insufficiency. He was transferred over to our center where we performed a bone marrow biopsy that showed diagnosis of acute myeloid leukemia. And you can see that he had normal karyotype, which is what is found at identification of the disease in approximately half of patients. But next-gen sequencing demonstrated multiple mutations, including a presence of NPM1, TET2, DMNT3A, and most significantly, FLT3 ITD with a high, what we call allelic ratio. His other workup, his performance status, and as I said, his cardiac function was normal. So for these patients, typically what we would use as standard of care would be to give this sort of 60-year-old gentleman the opportunity to achieve a remission with a standard intensive therapy with 7+3, as well as the addition of a FLT3 inhibitor. So our standard FLT3 inhibitor is midostaurin. This is actually what we call not a specifically targeted FLT3 inhibitor, but a multi-kinase inhibitor because it targets multiple different kinases and actually was developed for the treatment of solid tumors with other tyrosine kinase receptor abnormalities. The addition of midostaurin, as we all know, to standard 7+3 did not improve the CR rate. It was about 54 versus 59%, but was found to improve event-free and eventually overall survival. And you can see here the graphic on the right-hand side shows about a 7% improvement in overall survival over 4 years. What is now occurred in the last 5 years since the approval of midostaurin for this indication is the development of next generation FLT3 inhibitors with higher potency and specificity for the mutant FLT3 gene with less reactivity with other non-FLT3 tyrosine kinases and with much higher and degree of, as I said, potency in vitro. And listed here are the results of preliminary early phase studies showing a significant improvement in the overall response rate from 59% to 84 to 89% in small groups of patients who received a next generation FLT3 inhibitor in addition to 7+3. So the question now is, can we substitute or replace midostaurin with one of these tyrosine kinases? And you can see on the left-hand side the schema of some of these trials where 7+3 is followed by some FLT3 tyrosine kinase inhibitor, and then that tyrosine kinase inhibitor is incorporated throughout consolidation and following allogeneic stem cell transplantation. So there were 2 studies presented this year starting to show that there may be hope that a newer generation FLT3 inhibitor may soon replace midostaurin in this particular clinical setting. So the first data was the results of a much anticipated phase 3 trial where patients with newly diagnosed FLT3 ITD AML were treated with the FLT3 ITD inhibitor quizartinib in combination with standard induction therapy with cytarabine and anthracycline. Shown here is, again, the basic schema. I would like to highlight that quizartinib is a highly potent inhibitor only against FLT3 ITD. It does not have activity against tyrosine kinase domain inhibitor. I also want to highlight that quizartinib was evaluated in the relapse refractory setting with a positive phase 3 study, but at least in the United States was not approved for that indication due to concern about side effects, including QTc prolongation. In this particular trial, which enrolled hundreds of patients with newly diagnosed FLT3 ITD, ranging in age from 18 to 75, you can see that the majority of these patients had intermediate risk cytogenetics. About half of them, as we would expect, have mutated NPM1, and all of them have varying degrees of ITD mutation with variable white blood cell counts at the time of presentation. The primary endpoint of this study was looking at improvement in overall survival, and the phase 3 study was positive, demonstrating a survival benefit shown here of a median 31.9 months versus 15.1 months in patients receiving placebo alone. You can see that this was statistically significant with a p-value of 0.03 and a hazard ratio of 0.77. When we look at the effects of transplant, many of our patients who have FLT3 disease in this country are routinely recommended for allogeneic stem cell transplantation and first complete remission, a standard of care, based on data, again, from that ratified trial, suggesting the benefit of allogeneic stem cell transplantation in conjunction with FLT3 inhibitor upfront. Here is data censoring the quizartinib data for the time of transplantation, and you can see here that the survival advantage conferred by quizartinib obviously was preserved. In post-hoc analysis, patients who received allogeneic stem cell transplantation, and even those patients who did not receive allogeneic stem cell transplantation, again, seemed to benefit from quizartinib over placebo. And relapse-free survival, again, was almost tripled by the addition of quizartinib versus placebo. Now, relapse rates remained, however, high. You can see that although patients with quizartinib did have lower risk of relapse at about 2 years afterwards, 31% of patients, even of those receiving quizartinib, had relapsed as compared to 43%. So this still remains a difficult to treat disease, particularly in younger patients. The adverse events shown here were really consistent with what was seen with 7+3 alone, with mostly cytopenias and infectious complications. There was an incidence of QTc prolongation, but it was not significantly increased or thought to represent a new safety signal. So the conclusions is that this pivotal phase 3 trial, Quantum First, did validate the improvement in overall survival and other efficacy endpoints when added to standard induction chemotherapy. And you can see clinically meaningful improvements, not only in overall survival, but in many other endpoints in patients on this trial. And the safety, particularly the QTc prolongation, did not appear to be significant. So the presenters of this abstract at EHA concluded that this could quickly move into replace midostaurin as the standard of care. I would like to highlight, however, there are some differences in the design of this trial than the original ratified trial. So the quizartinib here was continued throughout consolidation and following allogeneic stem cell transplantation. So in the original ratified trial, there was no accommodation for allogeneic stem cell transplantation. So that maintenance was not administered following allogeneic stem cell transplantation, only for 12 months following consolidation chemotherapy, because the benefits of continuous maintenance FLT3 inhibitor were not known. We also see that the ages of these patients were 18 to 75, whereas the ages of the ratified trial were 18 to 60. And most importantly, the major criticism of this trial is the fact that the control group is a placebo control group and does not incorporate the use of midostaurin, which is our standard of care. So that these survival curves that we're seeing need to be somewhat taken with a grain of salt, because they're not superimposable necessarily on the results from the ratified trial. and other a much smaller phase 2 trial. Again, this is not a phase 3, but a phase 2 trial, which I presented at the ASCO 2022 meeting, looked at a different FLT3 inhibitor, crenolanib. And crenolanib, similar to gilteritinib, has activity against both ITD as well as TKD mutant AML. And the quizartinib data is also muddied by the fact that it only is looking at FLT3 ITD patients. And so the TKD patients, which are included in this study as well as the ratified trial, are not part of that original patient population. You can see here, similarly to the other trial, that patients received their crenolanib following standard 7+3. One difference between this trial and the ratify, as well as the quantum first trial, is that this trial utilized a higher dose of daunorubicin, 90 milligrams per meter squared, in patients under the age of 60, which has been shown in separate studies to confer a separate benefit in patients with FLT3 mutant disease. You can see again, the design was very similar. This was a small phase 2 study with a total of 44 patients, 29 under the age of 60 and 15 greater than 60 years of age. The majority of these patients, again, had intermediate or adverse ELN categorization, and again, had a multitude of mutations described here, including TKD mutations. The overall CR rate with this phase 2 trial in younger patients was 90%, with 89% of these patients considered MRD negative by flow cytometry. Older patients achieved an overall response rate of 80% and an MRD negativity rate of 45%. Again, both the quantum first and the ratified trial do not report MRD negative results for their patients. Whether that will be reported at a later date remains to be seen. The safety profile of crenolanib was very well tolerated, with mostly gastrointestinal side effects and no delay in the time for full platelet and ANC recovery. This agent did seem to add benefit to standard 7+3. The event-free survival and overall survival for all 44 patients has not been reached with a 45-month follow-up. Obviously, patients less than 60 years of age fared better than those that were older. And currently, at 3 years of follow-up, 71% of younger patients are still alive. You can see here also that the cumulative incidence of relapse also compares very favorably, although very, very small numbers. At 24 months, there was only about a 30% cumulative incidence of relapse, which compares well with what we are seeing with the quizartinib data. And in younger patients, the cumulative incidence of relapse is actually only 15%. Again, very, very small numbers, but there appears to not be any difference in the cumulative incidence of relapse between patients that underwent allotransplant and those who received chemo alone. So this trial, again, very small numbers, demonstrate that crenolanib can be safely combined with 7+3. And at least in these very small numbers of patients, this seems to be a promising approach compared to both the quizartinib, and clearly it's somewhat superior to the data that we're seeing in Ratify. So this is currently being pursued in a randomized phase 3 trial. For our patient, he did receive upfront therapy with midostaurin 7+3 and achieves a complete remission, and he goes on to receive consolidation. But before we can even think about transplant, and he did not have a social situation that made it easy for him to receive a transplantation, he unfortunately relapsed. And you can see we repeated the next-gen sequencing at the time of relapse, and he continued to have the same lesions that he had at diagnosis. So we moved him on to gilteritinib, another next-generation FLT3 inhibitor, which is approved for relapse refractory FLT3. Again, he had stable disease for several months and relapsed again. At this point, when we repeated his next-gen sequencing, and this is again just to highlight the importance of repeating, if possible, that next-gen sequencing at every relapse recurrence time point because of the known clonal evolution of this disease. Again, we now found that he had an IDH mutation in addition to the FLT3 and NPM1. And this led to questions about whether What should we target at this point? We now have therapies which could be active against both NPM1, FLT3, and IDH. So which one are we targeting? Now, out of the three of these, the one that's relatively new therapeutic target is the NPM1. And we now have the availability of newer class of agents called Menin inhibitors. Shown here is the Menin protein. Menin was initially identified in patients with multiple endocrine neoplastic syndrome, hence the name Menin. It's a nuclear scaffold protein, as you can see here, which interacts with multiple other transcription factors and regulatory factors to affect gene transcription. The use of menin inhibitors, or why are we targeting them for treatment of acute myeloid leukemia, is because that we know that in patients that have MLL rearranged and NPM1 mutant, in some cases NPM1 mutant leukemias have a similar biology, that the menin interacts with the MLL or KMT2A complex, and this complex is very important, binds to the DNA, upregulates transcription factors, MEIS1, which then promote leukemia genesis and leukemic transformation and induce, as part of that leukemic transformation, a differentiation block. Inhibition of the binding of menin to this MLL complex releases it from the chromatin and decreases the activity of these multiple transcription factors, therefore allowing cells to undergo terminal differentiation and to inhibit their ability to promote leukemia genesis. There are multiple menin inhibitors in development. You can see them listed here. And we are participating in a phase 1 trial of one of these menin inhibitors, the COMET-001 trial. This is an early first-in-human trial examining this oral inhibitor in relapsed refractory AML, and then subsequently in a dose expansion cohort. Initial patients were unselected, mutation agnostic, and the phase 2 expansion, which we're completing now, is specifically for these two molecular subtypes, NPM1 and KMT2 rearranged. In data presented about a year and a half ago at the ASH meeting, we were able to determine a maximally tolerated dose. You can see here that the cohort escalation, and it was relatively well tolerated with evidence of some minor side effects, no evidence of QTc prolongation, and no dose discontinuation due to adverse events. In the first 12 patients, you can see here, most of these patients were heavily pretreated, but there was evidence in the first 6 out of 8 patients, or 12 patients, of a few patients achieving complete remission with monotherapy. A second menin inhibitor, SNDX-5613, is being examined again in other centers, and this data was recently reported at the last ASH meeting, looking at the results of up to 59 patients who had MLL rearrangements or NPM1 mutant disease. In this first in human study, the overall response rate was about 24%, which is significant given these, again, were very heavily pretreated patients, most of which had already received 7+3 or Ven/Aza. And you can see that in about 9 of these patients, this monotherapy really led to durable responses. There was evidence of clinical differentiation syndrome with this agent, as well, again, as you can see here, QTc prolongation, which ended up being the dose-limiting toxicity. And this drug is now entering phase 2 trial investigation for these patients. As you can see here, one thing that has emerged from treatment, both with the COMET drug, Cura oncology drug, and this drug, is evidence of clinical differentiation syndrome. And you can see in the bone marrows on the bottom, the profusion of neutrophils that are there after treatment, and the concomitant downregulation of stem cell precursor genes and upregulation of differentiation genes that we're seeing with this effect. So multiple of these targeted menin inhibitors are now in clinical trial. The Syndex complex has received a breakthrough status given the promising data. And so we anticipate many more of these agents to be moving into the clinical treatment of AML over the next year or two. There are data now. Now the question is, because most of these patients with NPM1 mutation are going to have IDH and FLT3 mutation, is there the possibility of combining these agents? And that is actually undergoing active clinical investigation at this time. So this patient received, actually went on, because of his NPM1 mutant, to receive a phase 1 spot on the Comet 1 study with the KO539. And he actually had a potent differentiation syndrome where his white count shot over 100,000. And we actually had to cytoreduce him with a couple doses of cytarabine. He was in the hospital for a prolonged period of time for management of differentiation syndrome and cytopenias resulting from that. And he was recently discharged home to the outpatient setting on cycle 3 of therapy with stable counts and at least a partial remission. So we are cautiously optimistic that he's received some clinical benefit from that agent. The backup plan for him, given he also has an IDH1 mutation, would be to look at whether IDH-based therapies might be a possibility for him. And that leads us to the next case presentation, who's a 72-year-old woman with just a history of atrial fibrillation and severe osteoarthritis and obesity. She does have a history of recurrent sinus infections and really presented with reduced functional status, fatigue, dyspnea, and really decreased mobility, in part because of her arthritis. Given the fact that she was not very mobile, she was referred to an orthopedic surgeon for possible knee replacement. And the pre-op lab work showed here a pancytopenia with a leukopenia with a white count of 2.3, hemoglobin 7.3, decreased ANC of 200, and 18% circulating blasts. Bone marrow confirmed AML, and she was found to have mutations in IDH1, DMNT3A, as well as trisomy 8 cytogenetics. So here in the US, we have the availability of 2 IDH inhibitors, ivosidenib, which is an inhibitor of IDH1, and enasidenib, which is an inhibitor of IDH2. These are used both in the de novo setting as well as in the relapse refractory setting, where they have an overall response rate of about 40%, but a true CR rate of only about 20 to 24%. Also, side effects include less delayed differentiation effect. Shown here is sort of a summary of when these drugs were approved and some of the data in the relapse refractory and newly diagnosed setting. You can see again, although these are effective, they only are effective in about 20 to 30% of patients. And the response really is in the area of months. So we do know that IDH mutation upregulates and increases dependence to BCL2. So patients who have IDH mutant disease can respond very nicely to venetoclax. So, and there is recent data published with the Agile trial showing that the combination of ivosidenib and azacitidine is better than azacitidine alone. So this obviously brings up the question, could we use doublet or triplet therapy to treat our patients that have IDH mutant disease? And so this trial was a result of a phase 1b performed at MD Anderson Cancer Center, where they're looking at ivosidenib plus venetoclax plus or minus azacitidine in patients with IDH mutant disease. And you can see here, because of this triplet therapy, they did need to have a couple different regimens. You can see that the original dose regimens, we looked at the combination of venetoclax and ivosidenib, and the 2 later cohorts really looked at the triplet therapy of venetoclax, ivosidenib, and azacitidine at various doses. Patients who had not only de novo disease, but patients who had relapse refractory AML and secondary AML were eligible for enrollment in this trial. You can see here, however, that the dose cohorts were relatively small. So these results were really reporting on a handful of patients at each of these combination doses. In general, the side effects were mostly due to neutropenia and increased risk of infection, as well as induction of tumor lysis syndrome, which we see with venetoclax, and differentiation syndrome that we see with the IDH inhibitors. There was no patients that died within 30 or 60 days of the triplet therapy. And you can see here that the first two cohorts looking at Ivo and venetoclax, the second cohort with the higher dose of venetoclax of 800 resulted in an overall response rate of about 100%. The triplet therapy, again, an overall response rate of 100% in all of these patients, albeit these were only 6 patients per group. You can see that particularly with the triplet therapy, the orange bar, which is the number of patients in CR/CRI as well as CR, was very impressive and sustained. And by PCR, these patients were clearing their evidence of any IDH1 mutant allele fraction. Shown here is the overall survival. And you can see again that the triplet therapy in the light blue seems to do, and the red appeared to have pronounced overall survival benefit, but all of these patients appeared to be surviving at least 12 to 24 months with this triplet therapy, which is an improvement, we think, upon what we can achieve with ivosidenib alone, and that the disease status and clearance of the disease mutant allele ratio did seem to correlate with improvement. So our patient actually was not aware of this data. She went on to receive a venetoclax azacitidine-based regimen, and she is still disease-free at about 24 months after initiation of venetoclax azacitidine, with the plan being to add the ivosidenib or do maintenance if at some point she's not able to continue on that. The next case is a similar situation where you have an elderly gentleman, 81-year-old, with some comorbidities. And he was actually diagnosed a couple years ago, again, with presenting with pancytopenia and having evidence of an IDH2 mutation. And he had an IDH2 R140Q mutation specifically. At that point, their data was not out with the upfront use of ivosidenib, or uncertain data whether that he would benefit from IDH2 inhibitor or ven-aza. So he received initial therapy in the community with decitabine alone, but then developed progressive pancytopenia. At this point, enasidenib had been approved, so he went on therapy with enasidenib as monotherapy. That worked for, again, 6 months, but then his counts started to deteriorate again. And then there was some early data about potentially the benefit of enasidenib and azacitidine. So his community physician then added azacitidine to enasidenib. And again, that gave him a few more months. And now he comes to see us and he has a recurrent disease with a persistent mutation. This is specifically an R140Q mutation. So there was a phase 3 trial that was performed in patients with IDH2 mutant disease, looking at whether enasidenib, the IDH2 inhibitor, would be better than any other conventional care regimens for treatment of this patient population. And the results of this phase 3 trial showed no benefit in overall survival with the combination or the comparison of enasidenib versus conventional care regimens, and could have received azacitidine or decitabine. And you can see here that potentially reasons for this include patients who were getting enasidenib after therapy, but essentially this trial did not demonstrate a clear benefit to enasidenib over other regimens in the relapse refractory setting. However, when taking a look at some of the biological features and biomarkers of the study, the authors went back and they said, well, this is probably one of the largest studies ever in patients who have IDH2 mutant disease. So is there any biomarker, any information that we can get from this trial, which was over 300 patients, that can inform us on when to use enasidenib or other therapy? So as you know, the most two common mutational subgroups with IDH2 mutant patients is R140Q and R172. So the authors went back and said, was there any difference in those two molecular subtypes? And you can see here that they demonstrate that although the variant to field ratio was the same, there was a higher, what we call mutational burden in patients that had R140 mutation. And R140, both patients in either group benefited from the enasidenib in the study, although it may not have been statistically significant, but there were differences based on the mutational subtype. So you can see that patients who had IDH2, R140 mutations actually had a high degree of other co-mutations, meaning RUNX1, SFF2, FLT3, and RAS. And these patients, although they had a benefit from the enasidenib, you can see here that the benefit or the response rates and the transfusion independence rates was just a little bit improved, 11% to 37%, 6% to 20%, and 12% to 37%. In contrast, patients who had IDH2 characterized by R172 mutations appeared to have a much higher response rate. And you can see here, overall response rates 50 to 60% with enasidenib, as opposed to 20 or 30%. And this may be because there's a different mutational profile for these patients. And interestingly enough, these patients responded even though they had co-mutations in TP53. So this suggests that potentially, if this data is validated in future studies, that looking at specifically the type of mutation in IDH2 mutant disease may be helpful. This may be why our patient did not do as well with the combination of enasidenib as we might have thought. He also went on to receive a venetoclax low-dose cytarabine-based regimen for his IDH2 mutant disease, and again remains in remission over 12 months later. The presence of these mutations may also allow us to delineate which patients with IDH2 disease should go on to a ven-based regimen, and which patients with R172 mutations should be treated with the enasidenib-based therapy. Again, additional studies are needed to confirm this. The last case I'd like to present is this case of an unfortunate 53-year-old woman who has just a very minor medical history of hypertension, uterine fibroids. And she works actually in a healthcare organization. She's an administrator, and she was having difficulty working because she was having progressive dizziness at work. And apparently she was at the point where she was practically like passing out. So she was referred to an emergency room, and she was found to have a low blood pressure, but she was also found to have a very low white blood cell count and a hemoglobin of like 5. So she received multiple transfusions, and she was sent to the primary care physician, who rechecked the CBC and noticed that there was a report of peripheral blasts. So therefore she was referred to the academic center for suspicion of acute leukemia. And the outside, after transfusion, her hemoglobin had got up to 9.1, but her white count was 2.3, platelets 52,000, and she had 9% blasts. On our center, she was had an ECOG about 1. She was a little bit dizzy, healthy appearing, normal exam. Her bone marrow biopsy again confirmed AML with 23% blasts. But she did have, which is a little unusual because of her age, evidence of MDS-related changes with her bone marrow biopsy. And to our dismay, she had a very complex cytogenetics with just multiple numerical and structural abnormalities, including deletion 5q, derivative 12, additional 20, and monosomy 7. Next-gen sequencing confirmed the presence of a p53 mutation, as well as another mutation and this TP53 mutation was associated with a very high variant allele frequency. So she's young, she's 53 years old. We know conventional chemotherapy for patients with complex karyotype and particularly p53 mutant disease probably leads to overall remission rates about 30 to 50%. And in patients with a high variant allele ratio, probably an overall survival benefit of only 4 to 5 months. So we thought about using venetoclax azacitidine in her case, but however, there's recent data that suggests that although patients with poor risk and intermediate risk cytogenetics can do very well with upfront venetoclax azacitidine based on the earlier trials, when you have poor risk cytogenetics in the specific presence of a p53 mutation, you can see that your overall response rate drops from about 70% to about 40%. Still better than AZA alone. So that's good. But when you look at overall survival of patients, and I focus your eyes to the left-hand side, the overall survival of p53 mutant patients with Ven-Aza is only 5 months, and is not statistically greater than what you would achieve with AZA alone in this setting. So the good news of this data is if you have poor risk cytogenetics and you don't have p53 mutant, you can see that you are still going to get, you could still get prolonged overall benefit. However, p53 mutant disease really does not respond very well to the addition of Ven over AZA in terms of overall survival. So we considered her for clinical trial, and the clinical trials that are of most promise for the use of p53 mutant disease are those that involve this macrophage immune checkpoint inhibitor targeting CD47. So magrolimab is an anti-CD47 antibody. CD47 is expressed in multiple cancers, including AML, and prevents these cells from being recognized, targeted, and phagocytosed by the host macrophage system. So by blocking CD47, we now are making these leukemia cells accessible to macrophages and amenable to macrophage-induced immune mechanisms. So this phase 1b trial was looking at newly diagnosed patients with AML, and in the results reported here, the results were specifically targeting patients that presented with newly diagnosed p53 mutant disease. You can see here that the CD47 agent was combined with azacitidine based on preclinical data suggesting that azacitidine would further enhance the surface expression of CD47 and thereby potentially improve the efficacy of magrolimab-directed therapy. Patients received the CD47 as a priming dose and then received further ramp-up doses. And this was administered largely in the outpatient setting with transfusion support. You can see here data presented on 72 patients with p53 mutant disease. Almost half of them had MDS-related changes, as in our patient. The overwhelming majority of these patients were above the age of 65. And again, similar to our patients, 80% of these patients had poor risk cytogenetics with high VAF levels, over 50%. So this was what we would consider a really poor risk category of patients to respond to any AML therapy. No patients had magrolimab dose reduction. There were adverse events, including infusion reaction. And because CD47 is expressed on older senescent red cells, a proportion of quarter patients had some evidence of hemolytic anemia with their first infusion. Now, this hemolytic anemia led to, on average, drops in their hemoglobin level from 1 to 2. However, there was a small percentage of patients that had greater than 2-gram reduction in their hemoglobin. And for this reason, magrolimab-based trials were temporarily placed on hold in the US for management of this hemolytic anemia. What was the overall response rate? You can see that overall response among all 52 patients was almost 50%, with a third of patients achieving a CR, and 50% of those patients achieving a CR had a MRD negative complete response. You can see on the right-hand side the bone marrow blast reduction with the therapy of azacitidine magrolimab. And shown here are the event-free and overall survival differences. The overall survival here was 10.8 months, which was impressive given the 4 to 5 months that we're seeing with the venetoclax azacitidine. And median follow-up, however, for the study was only about 8 months. And there was evidence of variant allele frequency decrease in these patients, as well as the evidence that patients who achieved a response could successfully go on to stem cell transplantation. And you can see here the results with the 9 patients going on to allogeneic stem cell transplantation and the improved survival with that post-transplant approach. So magrolimab azacitidine is again being studied in a phase 3 study to see whether this might be a way forward for these poor prognosis patients. So in summary, I hope this was useful. We discussed here using a number of different cases, newer therapies with next-gen FLT3 inhibitors, +7/+3 induction. We talked about menin inhibitors in the relapse refractory setting for MMP1 mutant and KT2 rearranged patients, as well as newer approaches and thoughts on IDH and T53 mutant patients. So I'm happy to take any questions. Here is a photo of the Roswell Park Comprehensive Cancer Center in Buffalo, New York. And once we're traveling, I'd happy to welcome anybody from the Mumbai Hematology Group that would like to come visit and tour our area. Thank you very much.
Thank you so much, Dr. Wang. This was beautiful, case-based, all novel agents, virtually everything that's available got discussed. We have 3 questions in the chat box, and then we will go to the faculty here. The first question is, inversion 16 AML with c-KIT, will you transplant in CR1?
So my answer is no. I think that the data that demonstrated that c-KIT is a poor prognostic marker did not include data with whether transplant benefits these individuals. In addition, for our inversion 16 patients now, we are routinely incorporating gemtuzumab into upfront therapy for younger fit patients. And we feel that the addition of the gemtuzumab may be helpful in overcoming the poor prognostic features of that disease. We also are in patients that you're concerned about the c-KIT mutation, also using in some patients dasatinib or c-KIT inhibitors as maintenance therapy. So I would not consider, unless there was evidence of clinical refractory disease or relapse disease, to transplant these patients in CR1, because I feel that with the additional agents to 7+3, hopefully I can overcome that.
Thank you. Great. The second question is, what are the indications of using 90 milligram per meter square of daunorubicin? When do you do that?
So I use 90 milligrams per meter squared of daunorubicin in patients that have FLT3 mutant disease, because there are a couple of cooperative group studies, as well as an MRC UK study that demonstrated that FLT3 mutant AML patients potentially have benefit from the addition of the higher dose of daunorubicin. That being said, I don't necessarily use it in all of my younger patients. Some of them have underlying cardiac disease. So in other patients, I would try not to necessarily use the higher daunorubicin dose, particularly in patients that have poor karyotype that might need an allogeneic stem cell transplantation, because I don't want to decrease their ejection fraction and render them ineligible. Do I use high dose cytarabine consolidation in intermediate risks? So for consolidation chemotherapy, I really feel that the higher doses of 3 grams per meter squared, I reserve only that dose for patients with favorable risk cytogenetics. In my review of the literature, there is no benefit to using 3 grams per meter squared in patients with intermediate risk. So my standard for intermediate risk disease is to use the 1.5 grams per meter squared consolidation. And our center for intermediate risk patients, we do add gemtuzumab to upfront induction 7+3. And those patients that get gemtuzumab upfront, I also give gemtuzumab plus the intermediate dose cytarabine for cycles 1 and 2 of consolidation, rather than using the 3 grams per meter squared. We've had a number of patients with 3 grams per meter squared who have intermediate risk disease that develop severe thrombocytopenia. And given the shortages in red blood cells and platelets, I feel that it's unnecessary to use that higher dose.
Thank you. We come to the faculty here, Dr. Chirag Shah.
Yes, thank you, madam. Now, a very day-to-day question for a newly diagnosed AML patient. Now, every time the diagnosis comes, everybody wants to start treatment right away. And now we want to wait for the cytogenetics, at least especially certain age group where we are worried about complex cytogenetics where 7+3 may not work. And then, so what do we do in that case? How long can we wait? Because, patients take second opinion. Everybody is very worried. Everybody says start right away, don't wait. And sometimes there are practical questions, also high counts and all. We have managed them with leukapheresis for a few days, but practically patients get very worried. And the second is the other test, the NGS panel, which takes even 10 to 14 days minimum. So
Right.
how do we manage this?
So we have adopted a couple approaches. We also have had many people be concerned about the leukocytosis. So what we typically do is we like to wait at least 3 to 5 days to get the results of cytogenetics and mutational testing. So if somebody comes in with a very, very high white blood cell count, what we will do is we will do leukapheresis. We will also give maybe a single dose of cytarabine, 1 gram, just a 1 gram single dose. To induce rapid cytoreduction. A couple of patients, we've had to do that a couple of times, in addition to hydrea and leukapheresis. If it's an older individual, I remind you that the Viale A trial with venetoclax azacitidine needed the patients to have a white count under 25,000 before starting venetoclax-based therapy. So I would not start a BCL2 inhibitor with a very, very high white blood cell count because of the huge risk of tumor lysis. So we have increasingly been doing a single dose of cytarabine for cytoreduction in addition to leukapheresis and hydrea. And we try to wait 3 to 5 days. If you don't have the ability to do a full cytogenetic karyotype, my center they have a couple fish probes. So they will look for the presence of the inversion 16 and the translocation 821. They will also look for abnormalities in 5 and 7. And MLL. So those 5 fish probes will allow you to grossly classify the cytogenetics before waiting for the full karyotype. And then in terms of NGS, our NGS does can take 7 to 10 days. So we have also utilized rapid PCR. So if you want to just know whether they're FLT3 ITD positive, TKD positive, or they have IDH mutations, those are the only ones that we would do differently. We would then just do PCR, even just for FLT3. So that gives you an idea in the first 7 days, whether on day 8, you have to give the FLT3 inhibitor. So we would potentially say, if your patient comes in, you make the diagnosis of AML, they have a high white count, give them a dose of cytarabine, give them hydrea, get your cytogenetics to do a FISH, do the FLT3 PCR, start your 7+3 if you need to, and then add on the drugs once you get those results. If you can get the FISH done, we generally wait at least 3 or 5 days to get that information, so we know whether it's a favorable risk to add GO, whether it's cytogenetic complex risk if they have a 5 or 7. So that gives us, I think, a quick turnaround, and that might be something you could consider discussing with your pathologist. I find it also very important because it's impossible for the pathologist to keep up with all the therapeutic developments in all of the different areas. So a lot of times if you ask them to do something, their answer will be no, because everybody's very busy. But if you go to them and you have a meeting and you show them the data and the new drugs that are available and how you would treat the patient differently, then they understand what you want. And then my pathologist, when I've had that discussion, suddenly become much more friendly.
You. We'll have 3 quick questions, one from Roshni, one from Krishna, and one from Priyanka. Short, quick questions.
When we have multiple co-mutations, except for the P53, how do we know what is the driver mutation we need to target in the first line?
And typically we target the FLT3. We think it's the most important driver mutation. FLT3 over IDH1, IDH2. IDH1, IDH2 could be clonal hematopoiesis.
And what is the connotation of this DNMT3A mutation along with other co-mutations?
Right now, it doesn't add very much prognostic significance. It's not a therapeutic target. So we tend to have the information that it's there, but at the current time, we don't use it therapeutically or prognostically.
Thank you.
Dr. Krishna.
Thank you. How good is venetoclax for FLT3 mutation AML if they are not fit for intensive therapy?
So there's data that's been presented that shows patients with FLT3 ITD do not necessarily benefit from venetoclax added to azacitidine. That FLT3 TKD mutations do very well with venetoclax azacitidine. However, if you don't know the FLT3 mutation status, it's fine to start with venetoclax azacitidine. And now in our center, we are moving towards triplet therapies where we're adding a FLT3 inhibitor to ven-aza for patients to try to improve those outcomes. So it is effective, but it's not sure that it's much more effective than aza alone, similarly to P53.
Thank you.
Thank you. Dr. Priyanka, one short question.
Elderly AML tolerated aza and ven for approximately 6 months, relapsed. So we do not have much availability of other agents. We have decitabine, azacitidine, venetoclax as of now, when though it is not upfront approved in India, but we have access to it. So how do you treat this case?
So if you fail ven-aza, you could switch to ven-decitabine. I don't know that I see a lot of efficacy by switching. There's some people that do 10-day decitabine with ven to see if they can restore the outcome. Personally, I've been using clinical trials, or I've actually used gemtuzumab in older unfit patients unable to receive ven-aza.
Any role of increasing the dose of venetoclax?
No.
Thank you.
Venetoclax is sensitizing the agents. It doesn't in itself as a single agent or dose response is not effective.
Thank you. One more question in the chat box. What is your take on maintenance therapy with hypomethylating agents in normal cytogenetics AML?
There is an oral hypomethylating agent, azacitidine, which is a 20-30% of IV azacitidine, which we are using in some maintenance. For our normal cytogenetics AML, I don't typically use hypomethylating agents unless I have that oral hypomethylating agent.
Thank you. And one more question is, how will you manage a pregnant AML woman who comes with AML in first trimester?
So in first trimester, unfortunately, I think that the options are limited. So we have recommended in that setting that patients unfortunately have to have an abortion. If they present in the second and third trimester, we have been able to successfully give cytotoxic therapy because the fetus is already formed, but in the first trimester, it would have to be a close discussion between how close she was to the second trimester, how early she was in her pregnancy, and whether it might be advisable at that point to terminate. Unfortunately, that's a difficult discussion and is always very hard.
Another question in the chat box, is NPM1 with FLT3 considered a good risk?
We think that if our FLT3 inhibitor studies with our next generation are able to improve outcomes, we do think that in the future, FLT3 disease overall might be considered similar to Ph positive ALL, which went from bad risk to good risk, right? And so we're hoping to see that with our FLT3 disease. NPM1 with FLT3 mutant is considered similar to just FLT3 overall. I don't think it adds. NPM1 is considered, without FLT3, is considered good risk, but until now, NPM1 with FLT3 is considered intermediate risk. But we're hoping with our new drugs that we can make FLT3 better.
Thank you, Dr. Wang. Unfortunately, you are
Sure.
Right. Thank you so much for being with us. You have been very kind.
My pleasure. I'm happy to do this. I hope you found this useful. Thank you. Bye.
Bye. So we'll go on to the next session. A pleasure to introduce Dr. Gaurav Goyal from Alabama, US. He's Assistant Professor, Hematology Oncology Division, University of Alabama at Birmingham. He was born and raised in a small town in North India obtained MBBS from NHL Municipal Medical College, Ahmedabad, and then moved to US, completed his residency from Nebraska. During his residency, he developed interest in hemato-oncology. He went on to pursue fellowship at Mayo Clinic. And during his fellowship, he developed a unique focus in the rare group of disorders, the histiocytic disorders. He conducted multiple studies describing the epidemiology, treatment, and outcome of this group of patients, and established the first of its kind multidisciplinary histiocytosis working group. He's led national and international guidelines on the diagnosis and management of these rare disorders, and subsequently recruited to join the Hematology Oncology Division at University of Alabama at Birmingham as assistant professor in 2019. He continues to conduct clinical and outcome research in these disorders. He has additionally developed special interest in survivorship research and has ongoing projects evaluating burden of morbidity and mortality in histiocytic disorders, lymphoma, and HIV and cancer. He also continues to educate the patients, families, and healthcare providers worldwide on the diagnosis and management of histiocytic disorders through online and in-person lectures. Today is going to speak to us on Rosai-Dorfman disease. Over to you, Dr. Gaurav.
Thank you, Dr. Agarwal, for the kind introduction. I'm going to try and share my screen. Just bear with me. This is my hometown. If you guys, I don't know if you've been to North India, anyone. Can you see my full screen? Okay, well, namaskar. Good evening, everyone, for inviting me. Special thanks to Dr. Agarwal and the Mumbai Hematology Group for inviting me to give this important topic. I wish I was there in person doing this talk, but we'll use Zoom this time. I have a special interest in histiocytosis, but my bread and butter clinical practice is lymphomas. I also see HIV-associated lymphomas. That's another special interest of mine. And I've been at the UAB for 3 years now. Here are my conflicts of interest. So the objectives of the talk would be to enable you to describe the classification and molecular features of histiocytic disorders. It is important to know the clinical features of Rosai-Dorfman disease. I'm going to use a lot of acronyms, RDD, and other histiocytic disorders in adults. And you should be able to describe the testing modalities and treatment strategies for Rosai-Dorfman disease. We'll review some cases from my clinic. These are rare diseases. I'm actually not sure how many of these cases you have in your practice, but it is likely that you are coming across them or they are there and they may not be diagnosed in a timely fashion, and I'll show you why. But we'll review clinical molecular features and conclude the cases. And if we have time, we'll talk some of the future directions we are going in the field. So here are 3 cases from my clinic, giving you 3 different flavors of the disease in different age groups. First case is an 81-year-old female presented with right inguinal lymph node that was biopsied, did not have any diagnosis clear. And next year had a left inguinal lymph node that was biopsied, showed Rosai-Dorfman disease. We did next generation sequencing, which I will call NGS going forward, and found to have KRAS mutation. Later on underwent staging studies with a PET scan, showed diffuse lymphadenopathy above and below the diaphragm and splenic uptake. Next case is a 31-year-old young male. He's fairly active, all of a sudden developed multiple skin papules all over the body that were itchy and tender, saw dermatology, had a biopsy, was diagnosed with Rosai-Dorfman disease. NGS on the biopsy failed, underwent a PET scan for staging, showed multiple skin lesions and some inguinal lymph nodes. Third case is a 61-year-old female, developed a very large fleshy lesion on the right hip area under the skin. Biopsy was called as granulomatous dermatitis. The lesion kept growing. A repeat biopsy was done, and this time a hematopathologist was involved. So Rosai-Dorfman disease diagnosis was made, found to have MAP2K1 mutation. Her PET scan showed FDG uptake in the skin region, along with iliac crest, as well as inguinal lymph node uptake. So histiocytic disorders are quite rare. We don't know the true incidence. It is estimated at 1 case per 100,000 per year. The cell of origin for Rosai-Dorfman disease is not yet entirely clear, but generally they are thought to be arising from dendritic cells, monocytes, or macrophages. There are over 50 subtypes of histiocytosis, and they have very variable presentation, range from mild to disseminated forms. This is the classification that was put forth by the Histiocyte Society in 2016. And Rosai-Dorfman disease actually falls in the R group of histiocytosis, which includes the familial Rosai-Dorfman disease as well as the sporadic Rosai-Dorfman disease. I have to state here that I am an adult hematologist, oncologist, so I don't see a lot of pediatric cases. I do consult on them sometimes, rarely, but most of my talk will be focused on adults today. Other important histiocytosis to know is the Langerhans cell histiocytosis that we'll call as LCH, Erdheim-Chester disease called as ECD. Other groups are the malignant histiocytosis that includes all the sarcomas, and the H group, which is HLH, that can be seen as a primary HLH or secondary HLH. So let's discuss the clinical and molecular features. The first description of Rosai-Dorfman disease was back in 60s. Dr. Rosai and Dorfman described 4 cases of children with massive lymphadenopathy. And that time it was called as sinus histiocytosis with massive lymphadenopathy. And later on, there was a large series of about 30 patients, and more recognition was made of this entity called as Rosai-Dorfman disease based on their names. Over the last decade, we have learned a lot about the molecular features and pathogenesis of histiocytic disorders. The first description of BRAF V600E mutation was made in 2010 in Erdheim-Chester disease, followed by LCH in 2012. As you can see in the pie chart, later on, several other mutations in the MAPK pathway were discovered in each of these disease entities. And slowly that led to the recognition of these as hematopoietic cancers. Before that, they were thought to be inflammatory or autoimmune conditions. So most recently, ECD was called as hematopoietic cancer by WHO in 2016. But what about Rosai-Dorfman disease? This question has been asked for me by many clinicians as well as patients, whether RDD is a cancer or not. Recently, RDD also has been found to have MAP kinase pathway mutations, most commonly KRAS and MAP2K1 mutations, but we have realized that over 50% of these cases have some sort of driver mutation in the kinases. And the more we sequence them, the more we find these mutations. Therefore, as a result of these discoveries of MAPK pathway mutations in RDD, the World Health Organization just recently, as I was putting together this talk, this came out and recognized Rosai-Dorfman disease as a neoplasm and included it under histiocytic and dendritic cell neoplasm classification. This slide depicts the clinical presentation of Rosai-Dorfman disease in our experience from a series we published a few years ago. The most common presentation actually we found was to have subcutaneous masses. This could be fleshy nodules, but you may not have an external component, but simply palpable internal nodules under the skin. Could be single or many nodules. But other presentations include lymphadenopathy, B symptoms, pain, some incidental findings, and respiratory symptoms. As you can see, the skin findings are not really very specific, and there are no real clinical symptoms that you see the patient in the clinic and you suspect, okay, that this patient may have Rosai-Dorfman disease or histiocytic disorder easily. The median age in adults is around 50 years, but if you take all comers, it is around 20 years because seen in pediatric cases as well. This slide highlights all the manifestations of Rosai-Dorfman disease in detail, along with approximate percentages based on our experience, as well as that published in the literature. Rosai-Dorfman disease tends to affect females more commonly than males. Most common involvement is actually skin, and shown in the figure here, and these lesions can be PET avid. And second most common involvement is lymph nodes, could be cervical lymphadenopathy or diffuse. Other organs that can be involved are bones, which are primarily osteolytic lesion, but can have mixed features of sclerosis and lytic lesions as well. It is important when you get imaging studies to get them from head to toe, because traditional PET scans that go up to mid-thigh may miss some of these lesions. Respiratory system involvement is usually seen as involvement of upper airways, sinuses, trachea, and so forth. Very rarely, Rosai-Dorfman disease can involve the nervous system, not as much parenchymal lesions, but dural-based lesions, retroperitoneum, but not as commonly seen as in other histiocytosis like Erdheim-Chester disease, rarely orbit. It is also important to know the associated conditions with Rosai-Dorfman disease. It's not just one disease. It seems like there is a spectrum and variability. It could be inherited, such as familial Rosai-Dorfman disease seen in children, could be associated with autoimmune lymphoproliferative syndrome, ALPS syndrome type 1. RDD lesions are also found in lymphoma biopsies often. It can also be seen with other histiocytic disorders. So it's important to review a large sample of a biopsy, especially lymph node, to rule out concomitant cancers. Another common association is autoimmune conditions, where it can be seen with lupus and other entities such as hemolytic anemia. Here are some more images depicting the diverse manifestations of RDD. The panel on the left shows in a case MIP image showing foot bone involvement, sinus involvement, as well as subcutaneous nodules that are all PET avid. Other unique manifestations are you're seeing the dural-based mass, orbital involvement, lymph node involvement in the neck, pericardial involvement, that is FDG avid, perinephric involvement, mostly presents as mass-like lesions in the hilum, but rarely can have some fibrosis. Breast involvement can be seen not infrequently, liver, respiratory tract, and testicular involvement as well. It is also important to know the key differences between Rosai-Dorfman disease and related histiocytosis, because as I will show, these can actually co-occur, and these can be on the differential diagnosis. In contrast to Rosai-Dorfman disease, ECD does not typically cause skin nodules or lymph node involvement. The classic and most common feature of ECD is the involvement of knee bones in a symmetric fashion that can be seen on MRI, bone scan, or PET CT scan. Other features unique to ECD are cardiac involvement, right atrial tumor, aortic casing and casing of the aorta. Very common to see pituitary abnormalities and endocrinopathies, posterior fossa involvement in the cerebellum especially. A unique feature is the xanthelasma, these yellow patches around the eyes, and the hairy kidney with this feature that is that could be seen in some other entities, very rarely in Rosai-Dorfman disease as well. LCH is unique in that it's bone lesions. It's quite common to involve bones, but the bone lesions typically involve the flat bones, skull, jaw, ribs, spine, or hip bones. And the lesions typically tend to be these punched out, clean, burrowed lesions. And the other unique entity in LCH that is almost always smoking associated is pulmonary LCH, which is manifests as cysts or nodules. Lymph node involvement is quite rare, but can happen. Like ECD, LCH can cause diabetes insipidus and other pituitary hormone abnormalities. Skin involvement is not seen as skin nodules typically, but more as a papular rash. Similar to RDD, it can have dural-based lesions as well. Traditionally, we thought that these three diseases, ECD, LCH, and RDD, these were unique. But now we are learning that these can actually lie on a spectrum and can often manifest with mixed features. So RDD has been associated with LCH in lymph node biopsies, where RDD is the dominant component. RDD has been also seen in association with ECD, where we found it to be mostly seen in older males, with RDD involving the testicular tissue and mostly driven by MAP2K1 mutations. LCH and ECD can co-occur, where it is mostly with BRAF V600E mutation. The knowledge of these features are very important because if you see a patient with some of these features, you may end up doing additional biopsies to capture these entities that may change your management. Let's review the pathologic features and workup going forward for these diseases. This slide shows all the markers that are typically used for histiocytic disorders, their description, and also includes some molecular features such as the mutation analysis. So the first column here shows Rosai-Dorfman disease followed by LCH and ECD. CD68 is not very strongly seen in RDD, although can be positive. CD163 is strongly staining, it stains strongly in Rosai-Dorfman disease. S100 is mostly seen in RDD, but is not unique to it. Other stains that can differentiate them is LCH is usually CD1A or CD207 positive. Factor 13A is mostly seen in Erdheim-Chester disease, but can be rarely seen in Rosai-Dorfman disease. Other unique feature we found was the OCT2 marker that is a hallmark of Rosai-Dorfman disease, but is rarely seen in other histiocytosis. In terms of the mutational landscape, BRAF V600E mutation is almost never seen in Rosai-Dorfman disease. If I see that mutation, I usually think of other histiocytosis, but other MAPK pathway mutations are commonly seen in these entities. A unique feature, but not very specific to Rosai-Dorfman disease, is emperipoiesis, which is where the histiocytes engulf intact lymphocytes or or plasma cells. They are not mandatory. It's not mandatory to have emperipoiesis to make the diagnosis. And emperipoiesis can be seen in other entities as well, but it helps to capture the diagnosis. Here are some of the characteristic images of the stains that I discussed. The CD68 stain can be variably positive in histiocytes. CD163 stain very nicely depicts a histiocyte that has engulfed the intact lymphocytes, the phenomena of emperipoiesis, which is also evident on S100 stain. These histiocytes are almost always OCT2 positive, and cyclin D1 expression can be seen in a large subset of these cases. Now, these are the classic features. It is important to note that in extranodal sites, RDD may not have these features all the time, and it may have a lot of fibrosis. It's also not unusual to see RDD-like cells in biopsies from lymph nodes harboring lymphoma. Therefore, it is important that in order to rule out reactive Rosai-Dorfman-like proliferations, a large sample of lymph node be biopsied, and RDD-like cells should be occupying 10% or more of the sample. RDD can also mimic several other disorders. It's a rare disease, so it's not on our radar when we see patients in clinic. It is important to rule these out, especially IgG4-related disease. RDD lesions can have IgG4 staining positivity, but that usually does not meet the level that is needed to capture the diagnosis of IgG4-related disease. Other entities such as ECD, tuberculosis, retroperitoneal fibrosis, lymphoma need to be ruled out as well. Here are the initial evaluations that should be undertaken when you see a patient with suspected or confirmed RDD in the clinic. The key there is that we are trying to understand what organ systems are involved, and we're also trying to understand those disease associations. So you want to do a detailed history and a detailed physical exam, including skin exam, head and neck exam. At the same time, you also want to rule out or make sure the patients don't have history of autoimmune conditions, other cancers, other histiocytosis, or ALP syndrome. In pediatric cases, important to make sure that there is no family history, especially in certain areas of origin. Once the diagnosis of RDD is established, it is very critical to assess what organs are involved with the disease, which is something similar to what we call a staging in most cancers. It is recommended by guidelines to get FDG PET CT scan, including distal extremities. So we call it skull vertex to toes. In all cases with Rosai-Dorfman disease at diagnosis, as otherwise you can miss some of the lesions on other traditional images. It If PET scan is unavailable, of course, a CT scan of the body is a reasonable alternative. In children, I know there is concerns about radiation exposure, so whole body MRI has been proposed as an alternative. You may end up doing other imaging studies depending on what organs you're suspecting, especially for central nervous system involvement in the form of an MRI. Here are the various lab tests that are recommended for a case of Rosai-Dorfman disease. Like I said before, if you suspect autoimmune condition, it is very important to get testing for those inflammatory markers. If you suspect, if there is anemia, make sure there's no hemolytic anemia ongoing alongside. It is very important to get a adequate tissue biopsy specimen, not just for histopathologic evaluation, but also for molecular assessment for mutations. The mutational testing platform should include a broad panel of mutations in the MAP kinase pathway, including gene fusion assays, because fusions have been found as well, which can be targetable in histiocytosis. And these panels are usually more solid tumor focused, so similar to that, some panels similar to that would be reasonable. We don't typically recommend a bone marrow biopsy in people with Rosai-Dorfman disease unless there is cytopenia or abnormal peripheral smear. Germline mutation in SLC29A3, the gene that is associated with familial RDD, is suspected. It's only done if it is suspected in children. We'll review the treatment options for RDD. I tend to divide these into two groups, targeted therapies and conventional agents. Targeted therapies for RDD as of now include MEK inhibitors. There are several available. The most commonly used one is cobimetinib. Conventional agents, there is a long list of agents because there are many, many case reports or case series, and all agents have been used. I tend to divide them into immunosuppressants, immunomodulators, chemotherapy, which could be single agent or multi-agent, and other regimens such as non-systemic treatment, radiation, surgery, rituximab, and so forth. This is our experience with non-systemic treatment options. We found surgery to be effective, especially in patients with single skin lesion, but there are relapses that were seen in a third of cases, and some of them required systemic therapy eventually. Observation is a reasonable alternative to do if there are no symptoms, especially in patients with lymph node-only disease. But the patients need to be monitored closely. Radiation therapy, we have not found it to be particularly effective. Out of the 6 cases we used it in, we only saw a response in one patient with tracheal lesion, but eventually relapsed in the systemic organs and then required systemic therapy for KRAS mutation targeting. What about systemic treatment options that are conventional? Corticosteroids have traditionally been used the most. They tend to induce a response in 60% or so cases. However, the relapse rate is quite high. The other challenge with prednisone is that you have to do a very prolonged taper, and it has its own unique constellation of side effects, which affects the quality of life significantly. We have little experience with chemotherapy, such as cladribine. It showed responses in 2/3 of the cases, mostly used as no more than 3 to 4 cycles because of prolonged lymphopenia. We did not see any relapses at a follow-up of 16 months, but again, it's a small cohort, and it's hard to say which patients will respond to this drug. More recently, intermediate dose cytarabine has been used in CNS Rosai-Dorfman disease. However, out of those cases, the 5 cases, 2 actually relapsed, and 2 required maintenance lenalidomide. So again, the question about sustained remissions comes into play. Interestingly, rituximab has shown some response in people with immune-related Rosai-Dorfman disease, where it presents with autoimmune conditions. And in one study actually showed in extranodal Rosai-Dorfman disease to have a 2-year progression-free survival of 64%. In our experience, it has not really worked for entities other than immune-related RDD, but certainly an option to consider because it is time-limited therapy. Other immunosuppressants have been used as well in immune-related or lymph node-only disease. There is accumulating evidence from case reports and series that immunomodulators like thalidomide and lenalidomide may have good activity in Rosai-Dorfman disease, especially in the case reports that have been published so far show prolonged complete responses in refractory cases of Rosai-Dorfman disease with approximately 1 year treatment duration. Imatinib has been reported in 2 cases with 1 responder. It's not usually used in histiocytosis anymore. Due to the discovery of MAP kinase pathway mutations in Rosai-Dorfman disease, there is a lot of interest in using targeted therapies similar to how we have used in other cancers such as melanoma. So MEK inhibitors, the first landmark clinical study was a phase 2 trial of 18 patients led by Dr. Diamond in the US with histiocytosis. These were mostly ECD patients, but 2 were Rosai-Dorfman disease and 2 had mixed ECD and RDD. Almost all cases responded, as you can see on the waterfall plot on the right. And this study led to an FDA breakthrough designation for cobimetinib in BRAF wild-type histiocytic neoplasms. We recently compiled our own experience with the use of cobimetinib in 16 patients with Rosai-Dorfman disease. As you can see in the graphic on the left, we treated 16 patients with variable doses. Overall response rate was 62%. However, very interestingly, people with KRAS and MEK, which is MAP2K mutations, these patients had almost universal responses at 87%, whereas people without these mutations or whose NGS was unsuccessful, the response rate was more close to 40%. As you can see in the progression-free survival chart, Kaplan-Meier curve on the right, there was a drastic difference in people who had MAPK mutated versus MAPK wild-type disease. This swimmer's plot highlights the details of each case treated with cobimetinib, including pertinent adverse effects. Although it is quite effective, there are side effects, most commonly rash. Other unique side effects are cardiac toxicity. It can reduce left ventricular ejection fraction. It can cause retinopathy, which is usually reversible, but it is important to keep an eye on that. So you may have to change the doses and make sure the patients are able to tolerate it. This is just an example of a case that had a complete response in bony, sinus, and subcutaneous lesions on a cobimetinib in our cohort. So the optimum treatment approach for RDD is unknown, but this is how I think through treatment of Rosai-Dorfman disease. If there is a clinical trial available, of course, that is recommended, but it is usually not the case given the rarity of the disease. Some patients with lymph node-only disease may have relapsing remitting course and can be simply monitored closely. However, in general, if patients are asymptomatic and they don't have any internal organ involvement, it is reasonable to just do surveillance imaging and keep an eye on them. However, if there is any of those internal organ involvement or they are symptomatic, it is important to start treatment to prevent morbidity as well as mortality. If there is a single lesion, especially like the skin, surgical resection is very reasonable as long as it is non-mutilating. We don't want to be doing very large heroic surgeries. If the lesions are very large or they are multifocal or multi-system, the way I think about treatments then is based on the presence or absence of MAPK pathway mutations. If there is a mutation present, I tend to favor a MEK inhibitor agent like cobimetinib. If there is no mutation present or the testing failed, then I can use either, you can consider conventional agent or a MEK inhibitor. Now, I realize that in many countries in locations, and there may be financial challenges and other reasons that MEK inhibitors may not be available. So in that case, a conventional agent based on the table I showed earlier is a reasonable alternative. Once treatment has been started, it is important to monitor for response and side effects. It is recommended to do a full body PET CT scan at least 2 to 3 months after starting treatment to see if the treatment is working. You may end up doing frequent imaging every few months till you get your best response and the patient is stable. And after that, you can space out your imaging studies to longer or even stop imaging them if they are doing well. It is important to get supportive care. In US, we call them palliative care or symptom management clinics because these patients can have other symptom burden that may not be adequately managed just with the Rosai-Dorfman disease treatments. And then other testing may be needed based on what treatments you're choosing and what complication arise. So let's go back to our cases that we reviewed earlier. So the first case, if you remember, was this 81-year-old female who had the KRAS mutated RDD with multiple lymph nodes, but she was asymptomatic. So I chose to observe her. Then her PET scan actually showed a partial metabolic response with observation alone. And she remains in sustained partial response. She still has disease, but she's old, so we choose to just keep an eye on her. So I see her once a year now. The second case, the 31-year-old male, we were not able to get NGS, but had multiple skin lesions. Tried corticosteroids, injectional as well as oral, did not work. Tried cobimetinib, actually did not work. You could call it stable disease or persistent disease. More recently, this year was started on lenalidomide, which actually, according to him, it seems like, and from clinical exam, it seems like the lesions are improving somewhat. So I would call it at least a stable disease. And so it seems to be working for him right now. The third case is the 61-year-old female with MAP2K mutated Rosai-Dorfman disease with skin, bone, and lymph node involvement. She underwent, initially, she had not undergone staging of the disease, so it was thought she only has skin lesions. She kept getting triamcinolone injections, had some response, but whenever she would stop, the lesions would come back, and they never really went away. And then she underwent a PET scan and found to have other lesions in the bone and lymph nodes. So systemic treatment with rituximab was tried, which did not lead to a response. Last year, she was started on cobimetinib that led to a very nice partial response to her lesions. And with the mutation in MAP2K1, that is not surprising. So she's doing very well on that dose of cobimetinib. Although we know a lot about these diseases now, there are a lot of challenges that remain, despite several advances in the understanding of pathogenesis and treatments. The most challenges in histiocytosis currently exist, especially in RDD and ECD, pertaining to the timely diagnosis of these entities. There are many reasons why a diagnosis is delayed or missed. Number one, that it has variable disease phenotype. It doesn't just always present like a lymphoma, just in similar symptoms, similar lab values, and so forth. So it can have very different presentations. Median number of biopsies in our experience was 2 to make a diagnosis. As you can see in the 3 cases I presented, 2 of them needed 2 biopsies, ranging from 1 to 6 biopsies. The mean time from symptom onset to diagnosis was 18 months. It can range from months to years, actually. These diseases tend to be underdiagnosed and fly under the radar because we don't usually think about histiocytosis when we are in clinic. It was not recognized as a cancer up until a few weeks ago. So that also leads to less research and less awareness in general among the cancer community. It's not mentioned in a lot of textbooks. We don't know the prevalence data exactly. It is definitely underreported. There are no classic lab abnormalities like leukemia. Your labs will mostly be normal, so you cannot point toward histiocytosis based on labs. And there are multiple mimics of the disease. Most of the time, these patients don't make it to a hematologist, oncologist until and unless a diagnosis has been made and they are very symptomatic and other empiric treatments have failed. In an attempt to improve the diagnosis and outcomes of histiocytosis, I helped establish the first of its kind histiocytosis working group with the help of my mentor, Dr. Ronald Go. We review cases on a monthly basis, and ultimately we created a guideline document based on existing data and our own experience to help guide clinicians from all subspecialties regarding the features of histiocytosis. I highly suggest that if you have time to please review this article. It gives you general features, what would prompt you to think about these diseases when you're in the community or talking to someone. Since RDD involves multiple organ systems of the body, it is important to have multidisciplinary care for these patients. On the left panel, you see our UAB histiocytosis team. So now, after I moved to UAB, we expanded the histiocytosis working group to make it Mayo UAB histiocytosis working group. Despite the pandemic, we continue to meet via Zoom, as I am meeting with you all right now. And we have expanded our work quite a bit in terms of research and clinical care as well. The other question that is unknown is, although we know that MEK inhibitors work, there is a concern, or the question that we don't know the answer to is, can we stop it at certain point? And that's really the next question that comes to mind. The data from BRAF inhibitors in ECD showed that if you stop the BRAF inhibitor, 75% of cases relapsed within 6 months of drug discontinuation. And anecdotally, it is found to be the same way in Rosai-Dorfman disease using MEK inhibitor as well. However, in my clinic, I typically tend to have a good discussion with patients. If they're having a lot of symptoms, I try to reduce the dose quite a bit. I have done drug holidays, but you have to monitor these patients very closely. It is really a case-by-case discussion and has to be done in collaboration with the oncologist or hematologist. We also don't really know the long-term outcomes in RDD. The largest study recently that we published was 64 patients over 20 years. And I do think there are a lot of other patients out there that are not being included in research, and they are being treated in different practices. With improvement in therapies, there is a growing survivor population of histiocytosis. This population is likely to be on long-term treatments with targeted therapies or other agents like immunomodulators, as I showed earlier. Additionally, these histiocytosis tend to involve multiple organs. Due to all these factors, people with RDD and other histiocytosis may be at a higher risk of chronic health conditions that can affect their long-term survival. These can also increase their risk of reduced quality of life, as well as increased healthcare needs. This aspect of late effects of cancer is now well known in other hematologic malignancies such as leukemia and lymphoma, but has not really been studied in RDD and other histiocytosis. To address these questions, we are undertaking a large national study in the US in collaboration with the Histiocytosis Association. In this study, we are establishing a national cohort, a large cohort of histiocytic neoplasm patients, where we will assess the burden of chronic health conditions, psychological outcomes, chronic pain, health-related quality of life. We'll also be addressing the burden of healthcare utilization, how often are they being hospitalized for various reasons, and the burden of mortality, so that we can have a large study to tell us what is the general outcomes of these disease, to be able to counsel patients better, and what are the causes of death, because we suspect that now the cause-specific mortality is switching from histiocytosis to other chronic health conditions and second cancers. So what are the takeaway suggestions I would like you to have? I know this is a rare disease and it may not be the priority right now, but at least know that these diseases exist. When you see these cases, it is very important to know about the organs involved, ideally by a PET CT scan. If not, then at least a CT scan or MRI. Please know about the pitfalls in diagnosis. These can mimic various entities, especially when you have skin lesions or retroperitoneal disease or bony lesions that can mimic IgG4 disease, tuberculosis, lymphoma, ECD, and so forth. It is now recommended that all patients undergo next generation sequencing, similar to how you do it in other solid tumors. So it is important to know the gene mutations and alterations that can affect that can actually help you diagnose as well. And there are cases where the pathologic features are not classic, and the presence of a mutation like a KRAS or a MAP2K mutation can help clinch a diagnosis. Please know about associated conditions. Your lymphoma patients or leukemia patients may have concomitant Rosai-Dorfman disease. Autoimmune condition patients can have Rosai-Dorfman disease that can affect your management. If there is a lymphoma or heme malignancy with RDD, the treatment is usually driven by the other hematologic malignancy, and because RDD is thought to be a bystander phenomena. In immune-related RDD, you can consider rituximab and other immunosuppressants. It is highly recommended to get a second opinion for diagnosis and treatment, especially when you first see a patient or is suspected. I get emails from all over all the time, and we are happy to help. The Histiocytosis Association, who you will hear from after my talk, they maintain a list of such providers, and most of us are very happy to collaborate to help with patient care. Finally, the most important thing is none of this is possible without research. So please encourage your patients to join the registry that's there. And there are a lot of webinars and research opportunities that come through that, and that would be encouraged. So there are several ongoing and future projects that I'm invested in right now. We do have our tumor board with the UAB and Mayo collaboration. We wrote our first National Cancer Comprehensive Network guidelines. That was a big win for the patients because it allows insurance payments, and the insurances look for NCCN guidelines in the US to pay for services. I'm conducting several translational studies, blood and tissue-based, to discover novel therapeutic targets. A lot of my interest is in undiagnosed histiocytosis, how to capture them, curative intent therapy using targeted agents and chemotherapy, and finally survivorship and late effects of these treatments and the diseases itself. Since these are rare, we have a longitudinal registry and biobank where all the patient samples are stored and we can do subsequent research. So I would like to thank the patients and families who participate in the studies, my mentors and collaborators within UAB, Mayo Clinic, and elsewhere, the Histiocytosis Working Group, my research team, funders and supporters, and ultimately thank you all for your time and attention. Dhanyavad. And I will take questions, I think after there are a couple other short presentations and introductions.
Thank you, Dr. Gaurav. That was fantastic. Your mastery on the subject was obvious. It's the first time we have heard you, and it's not often that we hear about this subject. So congratulations. And yes, before we come to the question and answer session, it's my pleasure to introduce Dana. Dana is Executive Director of the Histiocytosis Association, which is a global non-profit that is dedicated to addressing the unique needs of patients and families that are impacted by histiocytic disorders. She's also a histiocytosis patient herself, having been diagnosed with LCH at the tender age of 6 years. This association funds several research projects each year, in addition to providing educational and emotional support for families and patients and raising awareness around the world. I request Dana to say a few words.
Hello, thank you so much for the opportunity, and thank you all for being here today. I'm just going to share my screen really briefly. I have a very short presentation for you about our organization, just so that we can help you connect patients that you might interact with our organization in the event that we can support them as well. So as Dr. Agarwal said, the association is a global nonprofit. We were founded in 1986. And we are a patient advocacy group. So even though we are located in New Jersey, we do support patients and families around the world. And our mission is really all about helping everyone impacted by histiocytic disorders, including the physicians as well. These are just some of the different pillars that we focus on. So research through clinical trials, registries, and other studies. We have educational resources, including a physician directory. We have educational webinars and a lot of other information on our website. We provide emotional support through virtual opportunities such as peer-to-peer connect groups. We have an ambassador program where we can connect patients and families with others. And then we also share results to the community through constant communication across various channels. I won't read this, just to give you a little overview of some of the different things that we do, but we do actively participate in advocacy groups for rare disease. We focus on public health policy. We also were recently appointed to sit on the FDA's Rare Disease Advisory Panel, and we also recently were given an opportunity to help with the National Comprehensive Cancer Network. We have, like I said, webinars, support groups, an ambassador program, and really just a lot of amazing resources for the community. So we always encourage physicians to share our information with patients, so that way they can come to us for support beyond the office. This is what our website looks like, just so you can see a quick peek of the things that we have available online. If you do treat histiocytic disorders, we would encourage you to sign up for our physician directory. It's an interactive map. There's a link right on the page where you can register yourself and give us more information about the types of patients that you treat and how we can share your information with patients so that they can find you no matter where they are in the world. We also have a lot of information about trials and registries. So if you have something that you're aware of that is not there, or something that you're working on, we would love to make sure that we share that with the community so that they can patch in. And then just a little peek at some of the different things that we have for patients and families, newsreaders, podcasts, webinars, meetings that they can participate in. And then I will briefly mention, as you'll hear from Kathy Wisniewski with the Histiocyte Society, that we have been partnered together with the Histiocyte Society for over 35 years. Our goal is to alleviate their leadership of the administrative responsibilities of running a volunteer-based organization. They focus on the research, and so we support each other and partner in the fight against histiocytosis. And then that is demonstrated most profoundly through our annual research program. And we have an annual cycle of funding where we funded over 7 million in research. Over 194 grants have been awarded since we started the program. And so if you are interested in doing any research, I encourage you to take a look at our research program as well and apply for some funding to help us drive advancement in the knowledge and treatment options for histiocytosis. And this is just a really brief overview of what that grant process is like, but all of the applications face an evaluation, that a peer review process, and we fund several, like I said, every year. They receive grants at $50,000 US. So again, encourage you to check that out and to apply. And I'm going to just say thank you for the opportunity. It was wonderful to be able to hear the talk and to have a chance see all of your faces. Thank you for giving us a chance to share what we do. And I'll pass it back to Dr. Agarwal.
Thank you, Dana, for that brief talk. It's very impressive, the kind of work that you've been putting up and the beautiful way you put it up to the, you'll be happy to know that we've got about 25 countries listening to you today. So with that, I'll move to introducing Kathy. She has worked with the Histiocytosis Association and the Histiocyte Society since 2008. During that time, she has held many roles in both the organizations, but today her primary responsibilities lie in managing the Histiocytosis Association's research grant program, producing the association's podcast entitled Beyond the Diagnosis, and managing the Histiocyte Society, a global group of over 200 physicians and scientists dedicated to researching histiocytosis, finding better treatments, and ultimately a cure. So, Kathy, over to you.
Thank you so much. Like Diana said, it is definitely an honor and a privilege to be with you here today. And I just wanted to share a little bit with you about the Histiocyte Society and what the work that we do. So as it was mentioned, the Histiocyte Society is a nonprofit organization. It's a membership group which consists of 250 physicians and scientists from around the world, and they are committed to improving the lives and patients of patients with histiocytic disorders through their clinical and laboratory research. Now, members of this organization are considered to be the leaders in understanding and treating the histiocytic disorders. So it all started back in May of 1985. There was a historic international workshop that took place in Philadelphia. It was initiated by Dr. Giulio D'Angio from the University of Pennsylvania Hospital. And this historic meeting led to the founding of the Histiocyte Society. And there were only 15 attendees at that time. But it grew subsequently to where we are now, which is 250 physicians and scientists all over the world dedicated to research into the histiocytoses. So this group of physicians is an international society from all over. They've provided a forum for the exchange of information and a framework for organized activities of fundamental importance. So if you want to take a look at where all of our members are located, I did a little map for you. We have physicians and scientists all over the world, and that is one of the things we're most proud of with this organization, is that we do have the entire world represented. So all of these physicians and scientists work tirelessly towards our mission, which is to advance the knowledge about and improve outcomes for patients with histiocytic disorders through clinical and basic research and education. And this will lead us to our vision, which is to be the world leaders in understanding histiocytic disorders and improving outcomes. So the goals that the society has is to improve the state of knowledge of the histiocytic disorders and improve the welfare of patients with these disorders, to promote, facilitate, and carry out research on histiocytic disorders, to facilitate and provide a forum for healthcare professionals for effective communication, to promote education and educate physicians, scientists, and others in matters related to the histiocytic disorders, and also to advise lay organizations in education and other manners, just like the collaboration between the Society and the Histiocytosis Association. So some of the accomplishments that the Society has had is that they've been able to establish several scientific standards for histiocytic disorders, and they are accepted worldwide. And those include a common language of uniform disease classification, a standardized diagnostic criteria, and guidelines for patient evaluation and follow-up. So as we move into the future, we would love to have you join us if you are interested in histiocytoses, and there are a couple of ways to get involved. First, you can become a member, and there are many benefits associated with becoming a member, and that is the website there if you are interested in that. We also hold an annual meeting, and this year our meeting is in Stockholm in September, and there's the meeting website if you want more information there. And with that, I would love to thank you for your time and allowing me to share with you a little bit about the Society. If you have any questions, there's my email address, and you can feel free to email me and I will help you as best I can. Thank you.
Thank you, Kathy. That was wonderful. Again, briefly, you described a lot of things. And though Asia had a very poor representation in your group, but after this talk and today's day, I'm sure many, many people will join you. So now, Gaurav, we come to you for the questions. First of all, once again, congratulations. At a very young age, you have developed a big name for you. Coming from a small place in India, you move and then you do your best to develop a place for you and make everybody notice of you. Fantastic. Before I ask the faculty who are present over here to ask a question, let me cover the chat box questions. So we have, what dose of steroids and what taper is required? Should rituximab be used in combination with steroids like we do for other autoimmune disorders? And what is the role of topical steroids if there is only skin disease?
Yeah, it's sort of like, everybody is doing their own thing with steroids everywhere. There is no like one right way to do it. But typically, when I have used it, it's sort of similar to what you do for autoimmune hemolytic anemia or ITP. I do 1 mg per kg, 1 milligram per kilogram of prednisone, do it for at least 2 to 4 weeks nonstop. And then you do a very prolonged taper over a couple of months. Rituximab, I typically consider using it in cases with immune-related RDD. Certainly can be used in combination with steroids. Although, steroids are not without side effects. A lot of the problems that patients struggle with the steroids, not as much as the rituximab. So if you were to consider rituximab, you may not need to do that much steroids actually. And then you won't know what really helped the patient also. So I typically have not combined them, but it's not unreasonable. Topical steroids, the issue is RDD typically doesn't present like a rash. In LCH, topical steroids have been used, but the lesions are like nodules under the skin. So when local steroids have been used, it's been in the form of injections, triamcinolone and so forth. But if there is a rash, you can consider using it. Again, if they have a mutation, if you see other sites of disease, I typically don't even bother doing that. And you can try initially because we have this inherent thought that, that topical thing would be better. But sometimes those lesions can keep growing and they can grow to very, very large sizes before these patients are considered for systemic therapy. So I don't want you to just keep trying that. If it doesn't work, you just go to something else right away.
Thank you, Gaurav. The next question is, how do you treat ECD?
That's another talk. Please invite me again. I've given a lot of those, but Deanna presented the website of Histio Association. So one of the webinars that I did on with Dr. Diamond on ECD is on the website. but mostly it's targeted therapy. ECD has completely changed. It's either BRAF inhibitors or MEK inhibitors in one short term. In countries where targeted therapies are not available, interferon can be considered, and some other systemic therapies can be used.
Thank you. Can corticosteroid treatment be administered via infusion IV rather than the tablets? The patients feel that the tablets are less effective.
Yes, I have seen that, especially in India. Injections feel like more stronger somehow. I mean, you can do it IV if you have resources, as long as the dosing is not extraordinarily high. You just match it to the same 1 mg per kilogram disease, but it's not something that you're going to be like, well, I'll do 3 days of steroids and then stop. What's going to happen with that is patient is going to feel good. They're going to love you. They're going to come back to you, but then the disease will come back again, and then you'll be in the same pickle again. So it's like a chronic disease. So acute managements typically don't work like that. But if they have a lot of symptoms in RDD, steroids certainly, short course of high dose IV steroids certainly can help calm the disease down.
Thank you. Siddharth Shankar, go ahead with your question.
Thank you. It was a really very nice lecture. And as Gaurav sir said, it is not discussed many times. My question is, you have advised to just monitor those patients who presented with only lymph node disease. So how frequently and how to monitor? And the second question is, if a patient who is not fit for aggressive therapy and diagnosed with RDD with systemic involvement, can we use upfront lenalidomide and dexamethasone, and what will be the dose of lenalidomide and dexamethasone?
Yeah, thank you. Good questions. So your first question is I actually remember the second question now. Not the
okay,
first.
How to monitor and how frequently we monitor those patients only lymph node disease, and how to monitor?
So lymph node only disease if it is asymptomatic. Now remember, these patients can have lymphoma. So it's very judiciously, when you do a PET scan or imaging, you see a large bulky FDG avid lymph node. You want to biopsy that to make sure it's not lymphoma, and the previous biopsy you did may be just a reactive RDD. If they have no symptoms, they're doing well. I want to see the tempo of the disease, right? So the first scan I do is 2 to 3 months. And if it is stable or better, then I space it out to 6 months. And then I space it out further. So the first case I presented, now I am doing annual scan. Maybe after one more scan, I will go to 2-year scan or something like that. But it's important to keep an eye, because we are also learning that a lot of these cases can have we don't understand it fully, but they can develop lymphomas or other cancers down the road. So it's important to monitor them. That's the most important thing, and to let them know if their symptoms get worse to call you.
So will you ask for repeat biopsy again after?
If they have a new thing come up? Yes, I think I did not mention this. I will tell you, every time you have a new issue come up, the molecular signature also changes. We have initially NGS that is negative, and then we do NGS later, and it does capture the mutation because the cellularity is quite low. So the NGS by itself, you cannot take it at face value. It may be just they didn't get enough DNA to capture all the hotspots for mutations. The second question was regarding the aggressive treatment in an older patient. And you had asked what treatment did you ask?
Can we use lenalidomide and dexamethasone upfront if the patient
that's not wrong at all. If you want to treat something like that. Now in older patients, lenalidomide is not aggressive, but it's a lot of side effects, as you may have used, it's chronic side effects. So I usually, if it is old patient, if there is an old patient, I use lower dose, 10 to 15 milligram. You can always go up. I wouldn't want to cause, number one thing is myelosuppression. Number two is terrible fatigue. You don't want to give them pills that they won't take. So in studies in myeloma and lymphoma, it's been shown people don't even take those pills anymore if they feel crappy and fatigued. So I do low dose. I don't do a lot of dex. When I have used lenalidomide, I've just used it single agent. I really don't know the dex role there. You can do it initially if you want to help, but dex will cause a lot of problems in older adults as well. But that's a reasonable approach. But MEK inhibitors, if accessible, I don't know if in India there are. I actually wanted to know. For melanoma, I'm sure there are, but the cost may be a barrier.
Yes.
But that's very tolerable as well at a low dose.
Thank you. Thank you.
Thank you, Siddharth. Dr. Manas.
Thanks for a wonderful talk. And thanks, Dr. Agarwal, for inviting Gaurav to present this rare entity, which can be perplexing at times. So my question is regarding, we've kind of partly answered that, but I would still like to know the duration of MEK inhibitors and what you're currently doing in your practice, because once you start, so the question again stemmed up from the whole BRAF experience in LCH. And and that is a big issue for us being in India. So what are you currently doing for your patients?
Yeah, so that's that's a thorn in, it's been bothering me, that question, because cost is a big concern, and then other side effects can happen with time. So I typically keep them on. Now the way I think about it, if they're tolerating, if they can afford the drug, I keep them on as long as they are handling it. If they are not tolerating, if they're having problems, I reduce the dose. Now, let's say they're doing well after 2 years or so, I'm just arbitrarily saying, then I can give them a break and then keep an eye on it. The interesting thing in BRAF inhibitor story is that when you stop the drug and the disease comes back, if you re-challenge them, the disease goes into remission again. There are very heavily oncogene addicted diseases. So it's not like they will have ton of mutations that will cause escape mechanism. So I would say you use the drug, you give a break, but I typically want to see a sustained remission for at least 1 to 2 years, after which I can give a break to them. But that's a break. I wouldn't say that discontinuation completely. I am looking at, we are trying to look at protocols where we can give them chemotherapy at the end, where if there are those little stem cells that will lead to the disease coming back. But that's only in research. I mean, you can try it in your clinic. But RDD, notoriously, chemo doesn't really work that well in RDD.
Thank you, Manas. Dr. Radhika.
Thank you, Dr. Gaurav. That was a beautiful presentation. So my question is, just recently only in my OP, the case came for follow-up. He's a 14-year child, lymph node biopsy-proven Rosai-Dorfman disease, presented with asymptomatic cervical lymphadenopathy. It's asymptomatic, but yet it is cosmetically disfiguring for a small, young 14-year child. For the last 8 months, I have been managing him with initially high dose of steroid, then tapering dose. Right now, I've been managing him with a maintenance dose of steroid, 2.5 mg. There is a mild reduction, but then still a significant lymph nodal mass is persistent, and it is disfiguring for a small school-going child. I was thinking of going ahead with a surgical option. I contacted plastic surgeons and all. Is that a right option? Is that a right step for me to take at this point of time, or should I wait and watch for some more time?
Yeah, typically, I don't give medical advice during webinars, but generally lymph node only disease, if it is only one site,
yeah, it's one side, but there are multiple. And
yeah, so there is a chance that it may grow back. In staging studies, if there is no other site elsewhere, you could consider it. If the disfiguring is is an issue, I remember seeing a case of a young child where the steroids and other things were tried for 2 years, 3 years. Yeah. And the disease was driven by a KRAS mutation. So not until, we had to convince the pediatric oncologist to actually give trametinib, and really went away completely. The question is, whether the surgery can take away all of the disease, whether the surgery by itself will be disfiguring or not. And that's one of the things that we are asking people to move away from, is to not do mutilating surgeries, because I've seen horror stories of amputations and so forth, and the disease comes right back. At the very least, next generation sequencing, if possible, would be recommended. I'm assuming you have it available. You do it for other cancers, to at least check for hotspots in KRAS and MAP2K1, if not very broad one. If they have those, I typically don't even consider local, especially a surgery. But rituximab could be something to consider. I've seen some people say that that works in lymph node only disease. To make sure something, try that. But those are the options you have. IMiDs are an option. I've not used them in children, so I don't know how your experience will be with that drug. But would typically not recommend. That's why I put it in my slide. Don't do mutilating surgeries, because that kid is going to grow up and he'll have a massive scar on the neck, and there's going to be contraction there eventually. So that's a challenge. Radiation will have its own challenges as well. With that large area, you're exposing the thyroid gland. So if there is that, steroids, you can only do so much of them in children. You could consider a short course of chemotherapy, cytarabine or cladribine. That's another thing, again, to see if that works. If after 2 cycles it doesn't work, you don't want to give too much of it also. I don't know if that helps. I sort of gave you the...
Rituximab, is the dose the same?
Yeah.
Is
Typically do
rituximab,
375 once a week for weekly for 4
doses.
doses. But you don't want to keep doing it. If it is not working, then you just stop. If it works, then you can redo it at a later point.
Because 14 years child steroid, how long I should? Already for last 8 months I've been
Correct.
on.
And that is really my big, thing that I keep telling people, that you can only give so much steroids into someone for their lifetime. And we think they are easy, cheap, but they got a lot of problems, and you can really cause late effects in their adrenals and a lot of other changes in their bodies, hypogonadism and so forth. So you have to be very careful. So I would think about other treatments in such cases. I would not use I typically move to other treatments very quickly.
But no surgery.
I mean, again, short of
medical any surgical.
So typically disfiguring surgeries are discouraged.
Thank you, Radhika.
Thank you, sir.
Roshni?
Thanks for sharing your experiences. I wanted to know how you counsel patients as to the patient may ask you, will I have indolent disease or will I have an aggressive disease? How long will I live? So how do you make that clinical judgment? Just like we do a judgment in LCH.
Very important question. That's the name of the game. Here we have to do counseling. So when I first sit with the patients, I call it my tape recorder. So that goes on. So, when I sit down and explain, because there's a lot of anxiety surrounding rare diseases, first I use the word cancer. You have to use it. It is what it is. It is a cancer, but then I say it is a slow growing cancer. In our cohort of 64 patients, 4 patients died, and none of them were from Rosai-Dorfman disease. So you can say these things with confidence, but it can cause a lot of morbidity. It is important to check for other complications, such as other lymphomas that can happen. But the survival can be excellent if monitored closely and if treated appropriately. So that's how I counsel my patients. I tell them that the mortality risk is extremely low to negligible, unless there is a critical organ involvement, which you will do a scan. It does not usually do skip lesions. It's not like somebody will have lymph nodes and the next day all of a sudden will have brain lesions and so forth. LCH, I guess that needs a different talk as well, but that's a little different entity. And in children, it can tend to be very aggressive, especially in young children, where it is thought to be generating from the myeloid progenitor cells. That's where you really want to cure it, give a lot of chemo. Here there is an art and there is a balance where you discuss with the patients. Even if you're not treating, some patients may not feel happy. Like, you're telling me I have cancer and you're not treating me. But we do the same for a lot of other cancers, right? We do the same for indolent lymphomas. So I treat lymphomas for a living, so I think of it like indolent lymphoma typically, if that makes any sense. Thank you for your question.
Yes, actually predict which patients will remain indolent and which will progress?
Tough to say. In my limited experience, if you're not going to quote me on that, I think the ones who have mutations, I don't typically just say, oh, let's just watch them for a long time. There are a handful of those that I watch them, but if they have other organs, if they have internal organ involvement, I tend to treat them with systemic therapy.
And is PET different in this disease versus lymphomas? Does it look different or is it?
No, we have looked at that actually. There is no specific way, but the FDG uptake the SUV max may not be as high as aggressive lymphomas, but really I wouldn't hang my hat on a PET scan just to guess. But certainly if you do a PET scan, somebody who did a neck biopsy and you do a PET scan, there is a large abdominal mass, which is SUV max is 30 versus the neck one, which was 6. I would go do a biopsy of the abdominal mass again to make sure there is no lymphoma or other cancer actually.
And one last question is, these are rare diseases. So would you actually, can we share digital path with you or your pathologist?
Yeah, I get emails all the time. I mean, just don't hold me to what I say because I'm not seeing the patients. But I would love to visit someday and see, how your practices are. I don't know where you are. I'm assuming you're all over the place in India and other countries, but I have not seen a histiocytosis case in India. And I would always say that, I wish I had a partner there, because, there's all that I'm doing, we could easily contribute there, which I would love to.
Thanks a lot.
Thank you, Roshni. Dr. Chirag.
I saw a patient many years ago limited to bone, and we gave him pomidronate at that time, and that gave a prolonged remission. And thereafter, I think repeated also sometime, then also once give 6-MP. Are these options?
Yeah, so I shared the 6-MP has been used. Pomidronate, it's interesting that you mentioned. I've not heard it being used in Rosai-Dorfman disease, but of course in LCH and ECD, I've seen some reports of that, the zoledronic acid and pomidronate. I mean, certainly, like I said, if you were to Google or PubMed search of Rosai-Dorfman disease, you'll think any chemo, any drug you can think of has been used. So it's hard to, the largest study we have is 60 patients. So, it's hard to tell what works, but I mean, whatever works is reasonable. But the important thing to make sure is you're not missing those cases, which will, 30 to 40% of the cases, I think, will have very, very sort of refractory course. And those are the cases you really don't want to keep trying empiric treatments, and you want to really identify those cases early on and be like, okay, this thing didn't work. Let's think about the second tier thing, some systemic therapy. But yeah, I mean, that's a reasonable approach. As long as they're tolerating it, you can certainly do that. Just make sure they don't have other organ involvement that you're missing.
No, we didn't do a PET scan ever, not even
I mean, you could have done CT or something. Yeah.
Now, I think that's a very important point.
Yeah, that's the one thing we've been hammering in everybody's brain, that, these are cancers. If you are doing PET scans for other cancers, please do them for this. And, the bony lesions you can miss on, as you may be aware, in lymphoma, you can miss it in CT scans.
Thank you.
Thank you, Chirag. Any other question for Gaurav or for Dana or Kathy?
I'm keeping you up late.
Okay, so if none, then before I hand over the platform to Dr. Manoj for official vote of thanks, I thank on behalf of Mumbai Hematology Group, all three of you for sparing your time and being with us for last 1.5 to 2 hours. Dr. Gaurav, Dana, and Kathy, thank you very much for exposing us to what you're doing. Over to Dr. Manoj.
Thank you.
Thank you, Dr. Gaurav, Diana, and Kathy for wonderful insights in such a rare disease. And I'm sure you talked about collaboration, and many in India would like to collaborate with you. I would also like to thank other two experts who spoke today, Dr. Eunice and Kjeld, for the wonderful lecture as well. Dr. Gaurav, I just wanted to inform you that you're being heard but not just from India, but from Kenya, Nepal, Bangladesh, UK, Philippines, Myanmar, Sri Lanka, Malaysia, USA, Indonesia, Egypt, Singapore, and Australia.
Wow.
So that's truly
I should have said good
your
afternoon.
talk, and I guess absolutely, absolutely. And I think the presentation of Dan and Kathy is also going to make a lot of relevance, because this is being heard at a global platform. All the expert discussions today for wonderful insights, Dr. Roshni, Dr. Chandran, Dr. Akanksha, Dr. Chirag, Dr. Manas, Dr. Shruti, Dr. Kunal, Dr. Sindura, Dr. Sanjeev, Dr. Radhika, Dr. Vikas, Dr. Bharat, Dr. Alka, Dr. Parthnatha, Dr. Priyanka, Dr. Ava, Dr. SVSS Prasad, Dr. Stalin, Dr. Satish, and Dr. Siddharth Shankar Ray. Please don't forget, tomorrow is the last day of this marathon web series. Sunday, 10th, 6:25. We have 3 speakers, Dr. Jeffrey Lipton from Canada, Dr. Simon from Oxford, UK, and Dr. T.
Okay, we lost Dr. Manoj. So thank you very much. Have a wonderful day ahead, Gaurav, Kathy, and Dana. And good night to everybody from India. And again, good day, good afternoon to everybody elsewhere. Have a wonderful day or the retiring time for you. Thank you. Bye-bye.
Thank you. Bye.
Thank you.